All right, good afternoon. Welcome, welcome. It's great to see everybody. We are really excited to kick the course off this afternoon. Thanks so much for coming. Welcome to San Francisco and to the 20th annual UCSF Sports Medicine Conference. With the co-chairs, we're really excited to welcome you here and hope you have a really great 3 days of learning and time here in downtown San Francisco. I'm Carlin Center. I'm the Chief of Primary Care Sports Medicine here at UCSF. I practice in San Francisco mostly. I am a member of the Women's Sports Medicine Center here at UCSF and team doctor for the Washington High School Eagles, University of San Francisco, and the San Francisco Giants. And I'll toss it to Kim.
Hi there, my name is Kim Connors. I'm an athletic trainer. I work at both our Orthopaedic Institute as well as our Redwood Shores facility. And I also work out at Lowell High School. Go Cardinals. I think that's it.
All right, I'm gonna bring this up just a little bit. I'm Danny Keller. I'm an associate clinical professor at the UCSF PT clinic at Mission Bay. And then I'm also one of the team physical therapists for Cal University, go Bears. And so I'm excited to meet some of you guys today. I'll be doing a couple talks and feel free to come find me if you have any questions.
And my name's Ellie LaRoque, and I'm one of the sports medicine orthopedic surgeons with the UCSF department. And I work in San Francisco out of the Mission Bay area and then also part-time in Redwood Shores. And I also am the orthopedic clinic manager for the Redwood Shores Clinic. In terms of the sports team that I cover, I'm covering Unipro Sarah High School in San Mateo. And I just as Danny said, I look forward to visiting with some of the people that I already know here, meeting some new people, and feel free to approach me at any point if you have any questions. And I'm also one of the founding members, like Carlin, in the Women's Sports Medicine Center.
All right, so we wanted to introduce you to the course. First, of course, please silence your devices. And really want to welcome you to the city. This is a picture from the field of Washington High School, which has arguably the best view, one of the best views in San Francisco. So I'm lucky to be there many weekends in the fall. So who can help? Questions, we're happy to take questions. The CME staff up front at the desk. Also, there's the app. And so, if you have a question, just put it in the app and the staff will answer. Our CME office staff are Sari and Dawn, and you've probably met them at the front. And our awesome athletic trainers will be around all weekend and also are a great source of information if you have questions.
Great, and then our next slide shows our UCSF Orthopedic Surgery Sports Medicine faculty who are going to be helping with the course, both giving lectures and also helping with the small group workshops. And the next slide, the top photos are our physician assistant team with UCSF in sports medicine. They're also going to be helping with the course. And then we have a couple of other guests from our UCSF Department of Orthopedic Surgery, such as Jeff Berry and Tim Baldwin, who are going to be helping with the course. And then the bottom pictures are our fellows this year in surgical sports medicine and primary care sports medicine, who are going to be helping with the course. Dr. Nirab Pandya is our pediatric orthopedic surgeon in sports medicine who's going to be involved with the course this weekend. And then we also have many athletic trainers who have done a lot of work behind the scenes also to make this course possible. So I wanted to say a specific thank you to them. We have some UCSF physical therapists who are going to be helping with the course, as well as some physical medicine and rehabilitation faculty. And we have a few visiting clinical instructors and conference instructors who are helping with the course. These are our course objectives. And this is our schedule for today, which is Thursday. I'm going to hand it over to Danny.
All right, I'm here to talk to you guys about all the exciting stuff, logistics, parking, and attendance verification. So, first thing, make sure you sign in on the sign-in sheet at the registration desk. I don't think Sari would let you through if you didn't already, but if you somehow got past her, make sure you sign in. You only need to sign in once, so you don't have to sign in every day when you come in. Just do it when you first check in. Okay. There is going to be a speaker survey that's sent out electronically to whatever email address you registered with. It's going to come from Qualtrics, so just be on the lookout for that. We know how it is to get surveys over and over again. Trust me, I've gotten lots of those emails. I know they're annoying to fill out, but they do really help us. It really helps us make the course better for you guys. So if you can take a couple seconds at lunch or in between breaks or when you're taking a coffee break or whatever and fill out the surveys, super helpful. So thank you in advance. If you didn't receive the email, just let us know, let the registration desk know, and they can make sure that you are getting those emails. If you are sending them to your spam box, then check spam, right? That's where they're at. It's best to complete it in real time just so you remember what the talk was about and whether you liked us or not and liked our jokes or not. So be feel for that. On mine, wait maybe a day to make sure you don't forget the jokes. For your CME certificates, so on Saturday, you'll receive an email again from Qualtrics with a personalized link for your evaluation. I would suggest filling this one out if you'd like a CME certificate. We're gonna name all the other ones CME certificate question marks, so you have to fill them all out. But make sure you do that to get your online certificate, okay? In terms of parking options, obviously you guys all parked today, but parking at the hotel is the most convenient location, obviously. Valet is super cheap at $91. Welcome to San Francisco. You can also self-park overnight for half the price at $45. So a lot of different options there. Good luck. In terms of where some of this parking is, the Embarcadero Center has multiple parking garages. So this kind of gives you a map for where to go there. It's over by Sephora if you want to stop and get some makeup while you're there. And then there's a Muni bus stop, cable car stop, BART station, ferry terminal. It's all within walking distance. This is a really nice location for public transit. So if you want to avoid spending all of your paycheck money on parking, then just take public transportation. In terms of transition time, we try to give enough time for you to be able to transition from one room to another. You guys should have a copy of the kind of the floor map, but the main auditorium is on the same floor as the workshop room. So last year you had to go downstairs to go to some of the workshops. This year we were able to keep it all on the same floor. So you can take a look here. We're in the Bayview room right now. So all the Seacliff rooms are on the other side. All right, I'm gonna pass it to Kim.
So I'm just going to go over some more logistics for you. Feel free to log into the Wi-Fi here at the hotel. That code is up on the screen for you. It's also out at the front. Slides and handouts will be available in the Whova app for you. In the breakout sessions, we will also have some physical handouts for you if you'd like that as well. Q&A, we will have a portion for that. And then polls will be conducted. We encourage you to be interactive with those polls. There are some goodies, which I will talk about in just a little bit. As far as workshops, check in 10 minutes before each workshop. Again, they're on the opposite side of where we are at now. Doors will close after the session starts, but we will have a little bit of a grace period there for you of 5 minutes. If for some reason you're on a wait list, we will have 2 recommendations for you. Sign up if there's not a full workshop, which as of this morning, there was a couple that still had some availability. And otherwise, you can come into this room and there will be a main session talk here. Okay.
How do you get on the wait list?
I believe up at the front, they can help you with that, or through the app, yes. Again, engagement is encouraged. There will be some giveaways for in participation. We do have some swag from UCSF, hotel, restaurant, and bar gift certificates, as well as complimentary registration for next year's course. Again, all of that is through the Whova app. There is a leaderboard contest, icebreaker contest, as well as caption contest. So make sure that you guys engage with that. Meals and snacks. Tomorrow I will have some recommendations out at the front for you, as well as a map. You can definitely look at those. We encourage you to make sure that you kind of plan ahead when you are going to that to maximize your time to get food. There are some on-site things. I just wanted to note that the Eclipse Bar and Grill here at the hotel does close at 11 and doesn't open again until the evening time. So that would not be a great choice for you. Again, if you have a recommendation, make sure that you put that in the Whova app for other people. We do have exhibitors that are just down the hall here. Make sure that you stop and enjoy the exhibitors that have helped us to put this conference on. There will be a welcome reception tonight with those exhibitors, so please feel free to interact with them. Upcoming events that we have in May as a team, an orthopedic team, as well as some volunteers that we have. We offer cardiac physicals for our San Francisco schools. Over 150 others to provide like 500 free physicals for these students. As far as some other events that we cover as athletic trainers and sports medicine teams, our physicians, some of our other providers, we cover races here in the city as well as out in Berkeley. We encourage you to help with those races. Come out and join our teams. It's a lot of fun. There's 4 different events that we cover, and there are emails that you will have access to sign up for those. I'm going to pass it to Carolyn.
All right. Yeah, we'd love to see you out at the events. It's really fun. It's nice to be in the community, of course, give back and energizing. And for folks who like sports medicine, covering something like a marathon, there's medical conditions that you see at the finish line of a marathon that you just don't see anywhere else. So come on out if that sounds interesting to you. We want to invite you to upcoming courses as well. So the UCSF Peds and Adult Spine Surgery course is going to be in Hawaii for those who are interested in some spine. It's going to be in July. And save the date. We'll be back here next year in December. Some other ways to connect with us. So this is our kind of social media slide, our women's sports medicine info. We also are proud of our faculty who started a podcast. Doctors Pandya, Feely, and Lansdowne have a podcast called 6 to 8 Weeks, which is a really fun, conversational, and educational podcast covering kind of a range of sports medicine topics and sports topics. It's hard to characterize, but it's an enjoyable listen. All right, anyone know where this is? You can shout it out. Kezar, this is Kezar. So I took this photo, those who've been around a while, you may remember in 2017, we had a pro soccer team called the San Francisco Deltas here, and that's when they actually redid, they put in those red seats from Candlestick into Kezar when the Deltas had their one and only and championship season. So great. Well, we will get started. Thanks to my co-chairs. And we'll get rolling, all right?
Careful of the lights.
All right. So we are going to kick it off with a section on knee and then a section on hip today, and then a section on bracing and exercises, all to do with the lower extremity. And I'm going to start by talking about the top 5 knee problems in primary care. I have no disclosures. And at the end of this talk, you'll be able to list 3 treatments for patients with patellofemoral pain syndrome, write a physical therapy protocol for a patient with a meniscal tear, describe the history of a patient with a meniscal root tear, list 3 exam findings for a patient with knee osteoarthritis, list the keys to ordering x-rays for a patient with knee osteoarthritis, and identify the key exam maneuver used to diagnose a patellar or quadriceps tendon rupture. And to just make sure that you get the take-home points, I did put let's see if I can go forward, a gold star on all of the take-home points. So, if you're zoning out, just focus in on those gold star slides. So I built this talk around the 3 most common causes of knee pain globally, and those are osteoarthritis, which affects 23% of adults greater than 40 years old, patellofemoral pain, which has a lifetime prevalence of 25%, and meniscal tears, which affect 12% of the adult population. And then 2 bonus conditions. So ACL tear and quad and patellar tendon rupture, because I think they're important. If you don't already have a framework for how you organize your thoughts with respect to the musculoskeletal evaluation, I would suggest this, which is HIPROT. HIPROT stands for history, inspection, palpation, range of motion, other tests. And I can remember, being a student and a resident and even a fellow, and, there's a lot coming at you. You're taking a lot in and just reciting, okay, history, inspection, palpation. If you do that and then you document that way and you present that way, you will have a comprehensive evaluation. So that's HIPROT. When we think about the 3 key knee conditions, here's how they compare and contrast. So patellofemoral pain syndrome is a younger patient. This is an overuse injury. These patients will have soft tissue swelling, but generally no effusion. They may endorse locking, but it's not really true locking. When I ask a patient, hey, is your knee locking? And they say yes, I say, well, tell me about it. Tell me about the last time that happened. Most patients with patellofemoral pain will say, well, when I get up from standing, it feels like it's making noise or it's catching. So that's different. The locking that's a red flag is, hey, my knee gets stuck and I can't move it. And that's where, there's a piece of, loose cartilage or a bony piece in the joint. These patients also may have instability, but typically this is instability downhill, downstairs, sort of in an AP direction. Also not really the red flag I'm looking for. What about meniscus tear patients? So these patients can be any age. They may have an acute injury. This may be more of a wear and tear process. They may or may not have an effusion. They will be locked if they have a bucket handle tear, and we'll talk about a bucket handle tear. They don't usually endorse instability. And then lastly, our patients with knee osteoarthritis, they may be older, they may have a history of trauma, and so they have post-traumatic arthritis. This can present either with a story of an acute flare or more of an insidious overuse type history. They may or may not have an effusion. Again, these folks may endorse locking, and again, usually what they're talking about is crepitus. And same as patellofemoral pain, they may endorse instability, and generally what's going on is if you ask, oh, tell me about the last time your knee was unstable, they'll say, well, I get pain and then my knee feels like it's unstable, it's gonna collapse. The red flag for instability is really torsional instability. So that's a sign of ligamentous tear. I'm walking around a corner and my knee feels like it's shifting. It's the shifting description that I'm really listening for when I'm speaking with a patient and asking about instability. This description of, yeah, it feels like my knee shifts in an odd and uncomfortable way. What about common causes of knee pain by location? So anterior knee, we're going to talk about in detail. Lateral, we won't talk in detail about IT band syndrome, but I do want you to know that in a young, active person, the most common cause of lateral knee pain is IT band syndrome. And we'll talk about that as well in the physical exam part. Medial pain could be a meniscus tear, could be knee OA and MCL. And then posterior, I think, is the broadest differential. Posterior knee pain could be a lot of things. All right, so let's do some cases. So this first case is a 15-year-old high school student who has anterior left knee pain for 3 months that started as she was increasing her running mileage during the cross-country season. She denies swelling, she denies locking, but the knee is popping. She does have instability when she's walking downstairs. The pain is worse up and down stairs and worse with prolonged sitting and with squatting and with kneeling. You do her exam. She has pes planus and hindfoot valgus and slightly valgus knees. Mild left quad atrophy, tender patellar facets, no effusion, intact range of motion. She has no meniscal findings, no ligamentous laxity, a positive Ober, and a stable single leg squat, but anterior pain on the left with that. All right, so we're going to try to launch a polling question. So we'll see how this goes. This is meant to be done in the app. And so I think if you go to Whova to this talk and look for polling questions, you should be able to log your response.
On the homepage is a polls.
Okay, on the homepage, there's a polls. And Scott, are you able to launch results? Oh, they're there. Awesome. Cool. Thanks, everybody. All right, so yes, totally agree with where people are going here. So this really describes patellofemoral pain. Could it be chondromalacia? It could, but she's a little bit younger, probably. What's the difference? Well, chondromalacia patella is really an MRI diagnosis. Presents the same way. It's just that patellofemoral pain really would have a normal MRI, and chondromalacia patella would have a little bit of fissuring or a little bit of changes on MRI in the patellofemoral joint. Why isn't this the tendinopathy? Well, she wasn't tender. I didn't tell you she was tender on the patellar quad tendon. And not PES, just because I didn't tell you she was tender on the PES. So some classic findings of patellofemoral pain. What are the history keys? This is anterior knee pain. It might be anterior medial, it might be anterior lateral, but in general, it's the front of the knee that hurts. Important to talk about training history and their occupational load. So this is really an overuse injury. There should be some sort of story that has to do with more load on the joint than usual. Or maybe they fell. Maybe they fell right onto the patella and have some sort of cartilage injury. That would be more like chondromalacia or cartilage injury of the patellofemoral joint. It's good to inquire about shoe life. Are they wearing their shoes for much too long? And then sometimes patients will come in. I think we've all had patients who come in with patellofemoral pain and say, well, I've done PT, I've done rehab. And I think it's good to inquire, well, tell me more about the rehab. Like, can you show me what you did? Can you talk me through the program? Because sometimes it hasn't really been a comprehensive program, or maybe they received a handout but didn't have a chance to go back. So just exploring, okay, tell me about what that physical therapy was like to see if you feel like, yeah, that was high quality rehab. And then also good to identify what this person's goals are with their training and with their occupation. What's the pathophysiology of patellofemoral pain syndrome? So it's maltracking, and that plays a key role in both patellofemoral pain syndrome and patellofemoral osteoarthritis. The concepts are that the patella has increased lateral tilt and increased lateral displacement. So a few biomechanical concepts. First is this concept of the Q angle, which some studies show does increase the risk of patellofemoral syndrome, and others say it does not. But the Q angle, as shown in the picture, is the angle between your anterior superior iliac spine, the front of your knee, and your ankle. The more knee valgus, or the higher your Q angle, the more the vector goes laterally on the patella. And so it'll theoretically put you at risk of having lateral patellar displacement. The other biomechanical factors that increase the risk of lateral patellar tracking are femoral internal rotation, which can happen because of weak hip abductors or weak gluteus medius, and tibial internal rotation, and that can be because of a flatter foot or hindfoot valgus. So when we think about the physical exam, which Dr. LaRocque is going to demonstrate, when we think about this for patellofemoral pain, these are really the keys. You're really trying to figure out, okay, what's the biomechanical problem that's causing this for this patient? Do they have weak hip abductors? Do they have quad atrophy? Do they have flat feet? And these are things, these are obviously modifiable risk factors. So treatment, the goal is to promote more medial tracking of the patella. And this is usually done in a multimodal way. So first, physical therapy, really looking to strengthen the glute, strengthen the medial quad. Taping or bracing, which I'll talk about. Aligning the feet, so if they have pes planus, thinking about an over-the-counter orthotic to provide support. Activity modification. And then really, if the patient tries this for 12 weeks or so and they haven't improved, that's when I would think about imaging and a sports medicine consult. A little bit about patellar taping. And anyone in the room use patellar taping with their patients? A few. So patellar taping can be a useful tool when your patient's having lateral tracking. And there's really two styles. You see them pictured here. Picture A is called McConnell taping. And this is sort of the most popular and the most classic patellar taping style. This is where you basically pull the patella laterally. You can tilt it a little bit. Evidence supports use. So when I recommend this to patients, I suggest that they do this before they work out or before they have a competition. It's useful in the short term, but long-term effects aren't clear. And then an alternative to McConnell taping is kinesiology taping. Different concept with kinesiology taping. In this situation, and this is shown in picture B, these tape strips are used to increase the space between the muscle and the fascia and to cause muscular activation. So this has been shown to reduce pain and improve function, and often is used in combination with exercise and/or physical therapy. Yeah.
How does it increase how does it help, did you say?
Yeah, so the question is, how does this help? So in the case of McConnell taping, it helps by medializing the patella. So you're basically like creating a buttress so that the patella is pushed in. And I tell patients like, look, this isn't gonna be what you wanna do for your whole life, but while we're waiting for your glutes to fire and your medial quad to fire, it's a reasonable short-term thing to try. See if you can play. I'm less clear on how kinesiology taping separates muscle from fascia. However, the idea here is sort of anteriorizing, bringing the kneecap forward, creates space, and so allows the patella to glide without causing that friction and pain. My approach, if someone benefits from the taping, particularly if someone benefits from McConnell taping, but they prefer to have a brace, I'll write them for a patellar stabilizing brace. When you look at the data for bracing for patellofemoral pain, it's pretty mixed. All right. So we're going to move on to case number 2. This is a 35-year-old man with medial-sided pain and swelling of the right knee for 4 months since he twisted his knee in a squat. He endorses catching. He has no locking and no instability. His symptoms are ongoing despite 12 weeks of physical therapy, and he brings with him normal knee x-rays. You do his exam and find that he has an effusion. His range of motion is slightly limited because of the effusion, and he feels tight. He has a tender medial joint line and no bony tenderness, so non-tender medial femoral condyle, non-tender medial plateau. He has medial knee pain with McMurray, squat, and Thessaly, and no ligamentous laxity. Okay, so again, if you would go into the app and take a look at the questions. The question is, what do you recommend next? A, a compression sleeve, B, a medial compartment unloader brace, C, a knee aspiration and steroid injection, or D, a knee MRI. All right, great. So yeah, different thoughts here. I agree with the majority of you. 88% of you said knee MRI. That's what I would do as well. We'll talk about why I would do that. I think you could argue for other options. I think there are situations where maybe an aspiration and steroid injection would feel like the right thing, particularly if you're sure that this isn't some sort of meniscus tear that needs surgery, or if the patient really prefers no surgery. If it's not a surgery, the patient's not a surgical candidate. An unloader brace could be helpful symptomatically, though I would say for a younger patient who's pretty athletic, the unloaders aren't as useful. So key physical exam maneuvers for meniscus tears, we really think about these 5 things. So is there an effusion? Is there joint line tenderness? McMurray, Thessaly, squat, and Dr. LaRoque will demonstrate these, but using all of these can really, as you stack up positives, you get more and more concerned, okay, this is seeming like a meniscus tear. And really your history and physical exam are key because meniscus findings are so common on MRI. More than 30% of patients 50 and older without osteoarthritis have meniscal pathology on MRI, and greater than 60% of patients with knee OA have meniscal pathology on MRI. So, your history and your physical exam are super important in this situation. We think about really 2 major kinds of meniscal tears, acute and degenerative. Acute being, there was some, as in this case, there was some kind of trauma, albeit, just a squat, but there was some moment where this happened. Degenerative being like, it's more insidious. Acute, we tend to think of as patients who are younger, degenerative as we get older. Both can have an effusion, although the acute tears tend to have an effusion right away. And both can have mechanical symptoms. Patients will endorse like catching and locking. But really, it's somewhat debatable. And when you read the literature on this, there's no like clear diagnostic validated criteria on what is an acute meniscus tear and what is a degenerative meniscus tear. And that becomes important when you think about who benefits from surgery and who doesn't benefit from surgery. But I would say, on this slide, the more factors that are lining up on sort of the bright green, the acute, we tend to refer those patients more for surgery. Whereas the ones who are more on the right, the more degenerative, we tend to treat with non-operative treatment. The vast majority of patients with meniscal tears benefit from non-operative treatment. So, of course, acutely calming down the pain and swelling, modifying activity. And then there's really a big body of literature now showing that physical therapy benefits patients as much as arthroscopy for meniscus tears. Typically, this is a 12-week physical therapy program that's quite intensive, and I'll talk about a few of these protocols. But again, similar reductions in pain compared to partial meniscectomy in adults. And then sometimes injections, and particularly if there's concomitant knee arthritis. I wanted to present this paper. This was published in the New England Journal in 2022 because this paper focused on physical therapy protocol for patients age 18 to 40. I think for probably 5, maybe 10 years, we've known that patients in their 50s, 60s, 70s, 80s who have degenerative meniscus tears and arthritis benefit from PT. But what about the younger patients? What if I'm 20 years old and I have an acute meniscus tear? Do I benefit from PT? And this paper would say yes. So these patients were 18 to 40. They went through 12 weeks they were randomized. Half went to PT, half had arthroscopic surgery. You can see that the PT protocol, this is no joke. They're going twice a week for 60 to 90 minutes. So, this is different from what most of our patients can access and what most of our physical therapy therapists have, the bandwidth to provide. But in a study situation, this is what they're doing. So I think it's important when we try to operationalize this to recognize, okay, there's some limitations to implementing this. But a very robust rehab protocol can be as beneficial as arthroscopic surgery. The other important thing to notice or to note about all this data is that in each of these studies where they randomized patients with meniscus tears to PT versus surgery, in each of these studies, and there are probably, there might be 8 or 10 of them now, 30% of patients who get randomized to PT cross over to surgery. So I always remember that because, typically I'll recommend non-operative treatment for these patients, but remembering that 3 out of 10 people won't get better until they have surgery. And so to make sure that we follow up with folks and make sure that they're benefiting from the PT, and if not, to consider sending them for arthroscopy. And then this paper was just in the New England Journal in October. So this paper really speaks about home exercises. What these researchers did was they randomized patients, these are 45 to 85-year-olds with meniscal tears and osteoarthritis. They randomized them to home physical therapy versus office-based physical therapy and showed no difference. And so I think this is encouraging to say, all right, sometimes it takes the time to get into PT and so on. So if we can arm our patients with a really robust home exercise program, as they did in this study, they can benefit too. I did put this protocol in your handout. So again, no joke. This is the tempo slides, and it's 28 slides that's in your syllabus that talks about the home exercise program. The slide deck is detailed. They use ankle weights. I do think it's all approachable. It's all stuff that I think my patients could do at home. So worth looking at and thinking about when we have our patients who maybe, have barriers to office-based PT. What about surgical treatment? So I talked about 3 out of 10 of these patients crossed over in these studies. So remembering that arthroscopy is an option for these patients if they're not getting better with PT or home exercises. I would consider that after 3 to 6 months of exercise therapy. And the studies all say too, they have a lower threshold for arthroscopy and when patients have mechanical symptoms, catching and locking. And then definite referral, urgent referrals when there's a concomitant ACL tear, a bucket handle tear, and a meniscal root tear. So bucket handle tear is shown here. This is where the meniscus tears and a piece of it flips up like the handle of a bucket. typical story, this is a younger person, there's been an acute injury. Usually this is medial, so they'll be tender medially. They will have a locked knee. They won't be able to fully extend. They will have a moderate to large effusion. These patients should be put on crutches. They should have urgent X-ray and MRI. They should have an urgent referral to sports medicine surgeon. What about meniscal root tear? Have folks taken care of patients with a meniscal root tear? A few. Meniscal root tears are kind of a hot topic in the world of sports medicine. So the meniscal root, the ones we're talking, the meniscus has two posterior roots. So there's a medial posterior root and a lateral posterior root. The root is key in stability of the meniscus. And if you have a root tear, it essentially is like having a complete meniscectomy. It makes the meniscus completely non-functional. So, but it can be repaired, but they're hard to pick up on history and physical, I will say. So just to have this in mind, these patients are usually in their 40s, 50s, maybe 60s. They come in and see you with acute knee pain. It can be posterior. The root is posterior. As you in the picture I drew here, the meniscus is purple and the roots are sort of those pink things way in the back. This is a posterior view of the tibia. So they'll come in 40 or 50 years old, relatively little trauma, like, oh, I stepped off a curb and felt my knee pop. And now I'm getting really bad posterior pain and my knee is swelling like crazy. So when you meet these folks, you'll do an X-ray, they won't really have any arthritis. Maybe, typically I'd be like, okay, this person probably has knee arthritis. You get an X-ray, there's no knee arthritis. These are folks to get an MRI on because maybe there's a root tear and that needs to be fixed and it needs to be fixed sooner than later. Because if we don't fix the root tear, they're at risk of breaking down that compartment and getting arthritis rapidly. All right, our third case. So this is a 60-year-old woman with 6 months of medial knee pain. She has swelling and instability, but no locking. The pain's worse with weight bearing and better with rest, ice, and NSAIDs. She's tried home exercises and PT, but has ongoing pain limiting her function, and she wonders what else you'd recommend that might help. On exam, she has neutral knee alignment when she's standing. She's tender at the medial joint line, the medial femoral condyle, and the medial tibial plateau. She has a small effusion, little crepitus. She has a positive McMurray, medial knee pain with squat, a positive Thessaly, and no ligamentous laxity. Okay, so again, a question for you. So what would you do next? Would you order knee x-rays, order a knee MRI, refer for arthroscopic debridement of the meniscus tear and lavage, or refer for total knee? Oh, okay, yeah, we have some disagreement. This gets interesting. So half would do a knee x-ray, 60% of you would do a knee x-ray, 34% say knee MRI, and I'll talk about that. I think the test of choice here would be to do a knee x-ray, and why? And the reason is you want to know if she has osteoarthritis, and her exam would make you think she does. So she has both, In green here are the findings consistent with osteoarthritis. In black are the meniscus findings. So she has both medial compartment OA and a medial meniscus tear. Here's the criteria for diagnosing OA. So it's really bony tenderness is what you're looking for on exam, crepitus as well. What does an X-ray get you? An X-ray increases your specificity. So you can be very sensitive. The sensitivity of the exam, it's 95% sensitive, but you increase your specificity if you get an X-ray. And so I would recommend an X-ray in this situation. Which X-rays? You want to get weight-bearing X-rays and 3 views so that you can appreciate the medial, lateral, and patellofemoral compartment. But always, if your patient can weight bear, always weight-bearing X-rays. The reason is it'll be much easier to tell if they have osteoarthritis than if they're non-weight-bearing. How do we treat knee OA? So I think, I always think about knee OA treatment in sort of 2 big buckets. There's non-pharmacologic treatment and pharmacologic treatment. Non-pharmacologic treatment, we're talking about weight management, talking about educational programs, exercise, Tai Chi, yoga, bracing. And then pharmacologic treatment, my go-to is topical diclofenac gel. And, oral NSAIDs, yes, but often people have contraindications. So really topical diclofenac gel is often my go-to. Injections, so the data not as strong for most injections. We'll talk a lot in this conference as the days go on about different injections. This is at a JAMA, and so they're looking at big data sets. Our injection data is smaller studies and not as strong as, say, the data around weight loss and weight management. So weight management, what do I tell patients? Well, if you have a BMI 25 or greater, you'll have benefit if you lose 5% or more of your body weight. And the benefit is decreased pain and improved function. This also, in one study, has been shown to reduce the risk of osteoarthritis progression. I think many of our patients are wondering, what is disease modifying? My knee is okay, I'm managing the pain, I want to know what I can do to prevent me needing a knee replacement. And I think this is one of those things, so weight loss. You probably saw in the New England Journal, big study looking at semaglutide, weight loss, and benefits for knee OA. They weren't really looking to see, independent of weight loss, did semaglutide lead to to improved function and less pain with knee OA. This was really when you give semaglutide, patients lost weight and they had decreased pain and improved function with their knee OA. These were patients with a BMI of 30 or higher. Supplements we'll talk about as the course goes on. I would say there are small benefits from these supplements, but what's not clear, A, the data is not super great, B, the benefits are small and it's unclear if they're clinically meaningful. But I would say come to Dr. Osterhaus's talk, come to our registered dietitian Lindsay Orbeda's talk, and they'll talk more about supplements. Okay. So a few last points with red flags. First, this is a 17-year-old female basketball player who landed from a rebound and felt a pop. She had immediate swelling, the knee feels unstable. On exam, she has a large effusion. Her range of motion is limited to 10 to 80, and the knee is just generally tender. You really can't do much of an exam. You can't really do her meniscus, but her Lockman is positive, as is her anterior drawer, and the rest of her ligaments feel stable. And so this is a classic description of a patient who's torn her ACL. Non-contact, felt a pop, large effusion. If you have that story in your clinic, honestly, I don't think it matters too much what the exam is, except for they have a large effusion. This patient needs x-rays, needs MRI. Lastly, I wanted to remind you about patellar and quad tendon ruptures, so that this is in your differential for your patient who comes in having had a traumatic event and really having trouble walking. These patients will have landed on a planted foot with their knee bent and felt a pop. They will have an effusion and be unable to straighten their leg. That's the key exam maneuver with these patients. So always, when you're meeting these patients who've come in, they felt a pop, the knee is acutely swollen, check their straight leg raise. Can they raise the leg up against your resistance? If yes, they don't have this. If no, think about quad or patellar tendon rupture. You probably also can feel the defect in these situations. This is a surgical urgency. Get them to your sports medicine surgeon. All right, that brings me to the end. I'll leave you with some resources. These are all in your syllabus. So for those of you who like podcasts, the Curbsiders, I did a couple episodes with them last summer. Some more sports medicine on the Curbsiders. And I think we covered the objectives. And this is a reminder to tell me that those exercise slides for the Tempo Study home exercise program for your patients are in your syllabus. So thanks for your attention. And I'll take a few questions. I know that Dr. LaRoque's going to come up and set up for the exam, but I'm happy to take a few questions as folks come up and set up. Yes?
I'm getting several patients with medial facet osteoarthritic changes on the medial portion of the patella. But most people track laterally, so what is the mechanism for medial facet wear?
Yeah, that's a good question. So why? So he's saying he has patients who have medial facet tenderness or wear on their imaging rather than lateral. I think I see the same thing, and I think I treat them sort of opposite the classic. I think it's less common than lateral wear, but yes, you will have. I think it's basically the opposite mechanics of what we see with.
But they're very valgus still.
Yeah.
Valgus leg.
Yeah.
Should be a lateral facet wear.
Yeah. And then they still, yeah, I don't know. I don't know why that is, but I would hesitate, like for those folks, I don't recommend McConnell taping because you're just going to load that medial facet. But you could think about the kinesiology taping, which is going to bring everything forward. Yes?
Shockwave seems to be coming up on the scene a lot more nowadays. So what do you think of shockwave specifically for OA in the knee joint?
That's a great question. Shockwave is really on the scene. So I would say mostly we are recommending shockwave for tendinopathy. I have not been recommending it for knee OA. But I will say disclosures, we don't perform shockwave in our office, so I'm also not up on all the smallest studies. But for tendinopathy, there is some good data for it. For those not familiar, shockwave, it's the same technology as like lithotripsy. So it's, ultrasound, I think, shockwave, pulsed ultrasound, pulse waves, that the same thing you use to break up a kidney stone, but can be applied to a tendon. And, really promising results in tendinopathy can be uncomfortable, but even in-season athletes can couple shockwave with physical therapy and have some good benefits. Thanks for the question. Okay, you ready?
Sure.
All right, I'm going to turn it over to Dr. LaRoque.
Great, we'll see if my mic works. I think it does, thank you. All right, so now we're gonna start the hands-on physical exam session for the knee. So I'm gonna walk you through it, and then, we'll try to take a few minutes for questions at the end as well. So let me stand down here. And this is Donna. She's gonna be the model for today. And as Carlin was talking about specifically, for example, with patellofemoral syndrome, for physical exam of the knee, I always do like to start just looking at the patient standing and just looking at, for example, their arches and then watching them walk. That just gives you an idea of, say, Q angle, things like that. In interest of time, we will skip the walking with Donna. And then for the next part of the exam, I actually do start with them sitting, just as she is now. And then if they still have, say, baggy pants on, something like that, I do like for them to roll both pant legs up or have shorts on, okay? Because you always want to compare to their non-affected side. So for today, in the sitting position, let's pretend that it's your right knee that's having an issue. So first, I would just look at both knees, see if I see any swelling, any redness, and then I would go to palpation. So for palpation, I'm going to point out just a few different things. So I do like to palpate over the patellar tendon, over the quad tendon, as Carlin was saying. Sometimes they'll have pain there, or you can have a defect if they have a quad tendon tear or patellar tendon tear. And then I like to palpate along the joint line, so this would be the lateral joint line. And we can help you with landmarks and finding these in the hands-on sessions too. And then I'm going to feel her medial joint line. And then I also like to feel the pes too. So that's a little bit inferior and anterior to the medial joint line. So if somebody has distal hamstring pes bursitis, sometimes they'll be tender there. The other thing I like to have them do when they're sitting is just simply straighten the knee. So go ahead and straighten your right knee. Good, and then bring it back down. And then straighten your left knee. Good, and then bring it back down. So if Donna had, say, a patellar tendon tear or a quad tendon tear, she would not be able to actively straighten the leg as she just did. And then the other thing is when you have them straighten the leg in that position, it just gives you an overall idea of patellar tracking. So there's something called a J sign or jumping J sign. We can go through that with you more later. But often when people are sitting and the knee's bent, then the kneecap's actually kind of captured in the trochlear groove, and as they go into extension, it jumps out of the groove laterally. So it's called the J sign. So I do like to do a quick knee extension test in the sitting position. Now we'll move on to supine. So let's have you lay down, yeah, correct, with your head up here and on your back. And for this part of the exam, we're gonna say that the left knee is the affected knee. So again, I like to have both pant legs up or shorts on, see if anything looks swollen. And then I do like to just check for swelling. So there's basically a milking test where you can milk any fluid on both sides under the patella, and then I just push down on the patella, and you'll feel a little tick tick where it's going through fluid to hit the trochlea, and you can literally feel it ticking off the trochlea. So especially if it's a young person and they've had an acute sports injury and they have an effusion, that's actually somebody that we would want to see in clinic. Next, I like to check the patellofemoral joint. So I just do a simple patellar grind test where I just push on the kneecap, move it side to side, see if that elicits pain or grinding, and that could indicate patellofemoral syndrome or maybe patellofemoral arthritis. And then I'll often do a quick test for patellar instability. So it's actually supposed to be done at about 20 degrees, okay? So sometimes I'll very slightly put my knee under her knee just to slightly bend her knee. And then the most common direction that people have patellar instability is lateral. So you just gently kind of push on the kneecap laterally, and there's a quadrant rating system based on the width of the kneecap. So you just estimate, do you think it's going over laterally about a quadrant, 2 quadrants, so 25%, 50%, 75%. And then you can also see if they have a good endpoint or not. So that would be the basic test for patellar instability. Then I like to check range of motion. I like to compare to the other side too, because some patients, their knee will actually hyperextend. I'm just gonna move this chair out of the way for a minute. Okay, so we'll check her range of motion, check to see if she has hyperextension, not really, and then flexion. Okay. And then I like to check the ligaments next, okay? Because these tests really shouldn't be very painful, and I like to do the non-painful tests first. So while she's at about 90 degrees, I'm gonna check anterior drawer, that's one of the tests for ACL, and posterior drawer, that's one of the tests for PCL. So I'm gonna secure her foot distally, and then I'm gonna pull forward on the tibia, that would be anterior drawer, and then push posteriorly on the tibia, that would be posterior drawer. Then I'm gonna move on to Lockman. So Lockman's described with the knee flexed at about 30 degrees. So especially if the leg is, say, big, muscular, heavy, I will often put my knee under the very distal femur. And then I just put my hand over it, and that secures the distal femur. Because the Lockman, you want to secure the distal femur, and you only want to really be moving the tibia. Okay, so then I'm going to move the tibia forward. And then you can see if it feels like there's increased excursion in terms of millimeters, and then you also want to see if it has a good endpoint or not, and then you can compare to the other knee. So there's a grading system. You've probably seen Lockman A, B. So A is it has a good endpoint when you pull the tibia forward, and B is it has a poor endpoint, okay? Then next I'll go into McMurray because, and then actually, while she's at 30, I just did Lockman, I'm gonna do varus and valgus, okay? So we do varus and valgus stress at 30 degrees and then at 0 degrees. So she's at 30 degrees right now. So I'm gonna go ahead and first valgus stress her. And I remember valgus has a G in it, so it's like gum sticking the inside of the knees together. So she's going into more of a knock-knee position, okay? So I'm doing valgus stress at 30 degrees, and then I'll do varus stress. That's making her go more bow-legged at 30 degrees. And again, you want to check for how much excursion you're feeling when you're doing these tests, but also if these tests have a good endpoint or not. And then very quickly, I will also do varus and valgus stress at 0 degrees. And if somebody opens up a lot at 0 degrees compared to, say, the other side, then that's actually a red flag that they might have, say, a multi-leg injury or had a history of a knee dislocation, something like that. So those are patients that we would want to see. So next, because she's still supine, I'm going to go into McMurray. So for McMurray, there are many variations. I was talking to Danny about this today. But the original test is described that you bring the patient into flexion. This is going to be a provocative test for, say, a meniscus tear. So you bring her into full flexion, and then we'll start with internal rotation first. So you can start with internal rotation. That also usually brings her into some valgus, and that will load and pull on the lateral meniscus, okay? and then you bring her into extension. And then you see if she has pain or popping, say laterally, that correlates with her typical symptoms. And then another variation is you do the same thing, so flexion, internal rotation, and some valgus, but you can also kind of do some extra twisting, sweeping motions as you go down. Okay, so that would be McMurray, more specifically testing for lateral meniscus, and then I'll do the same for medial. So I have her up flexed, I'm gonna externally rotate, and then that tends to put her in a little bit of varus, and then I can just twist down and see if she has pain or popping that reproduces her typical symptoms, say medially. Okay, next I'm gonna have you lay on your right side, so you're gonna be facing the audience with your hips sort of straight up and down. Perfect, okay. And then, yeah, you can bend this knee a little bit, and then this leg, I'm gonna have you keep the knee straight, a little bit of extension, and then just hold your leg up. Don't let me push your hip down. Okay, good. So that tests hip abduction strength. And so as Carlin was saying, it's really important, say with patellofemoral patients, that you wanna check that because it also gives, say myself and the patient, even more confidence that if they're weak there and they have patellofemoral pain, that if they had good physical therapy, they'll probably really improve. And then go ahead and lay on your stomach. So lastly, when they're laying down, I do have them go prone, and then I'm gonna do the Apley test, okay? So this is also a provocative test for, say, a meniscus tear. So you can just relax, and I'm gonna have you I'll bring the leg up to about 90 degrees. And with this test, you wanna push down, so kind of compression across the knee and the meniscus, and you're gonna rotate in, rotate out. And internal rotation, that would tend to load the lateral meniscus more, and then external rotation would load the medial meniscus more. And then I should say also with the McMurray, you also want some compression, okay? So with the Apley and with the McMurray, go ahead and lay on your back one more time. With the McMurray, it is also described and works best if there's some compression. So when I showed you the McMurray, I was holding her ankle, but you can definitely get some compressive force that way, or you can also hold the foot and get some compressive force doing the McMurray by holding through the foot. And then lastly, I'm gonna do 2 more tests. So go ahead and stand up for me. Okay, so next we'll do the squat test. So usually with the squat test, I'll start with her, her feet at neutral and then about, say, shoulder width apart. Perfect. And then just go ahead and go down into a deep squat. Good, and then come back up. And then you just see if that reproduces her pain. So Danny and I were talking about that, that the squat test actually has the highest sensitivity and specificity for meniscus tear. So it's quick, and I definitely recommend doing this if you suspect meniscus tear. And then go ahead and go a little bit, with your pigeon-toed, and then go ahead and do the same thing going down into a squat. This one's a little harder to do, good, and then come back up. So with the toes internally rotated, that brings the knees into some valgus, and that would tend to load the lateral meniscus more. And then I do the same thing with external rotation. Good, and then just repeat one more time. Okay, so that's external rotation and some varus, and then that would typically light up a medial meniscus tear more. And then lastly, I'm gonna show you the Thessaly. So for the Thessaly, I'll usually start with the non-affected knee first, just so they have an idea of kind of what I'm doing, because to the patients it seems a little bit like an odd test. And then you always want to make sure they're supporting themselves on something or offer support, especially if they have some balance issues. So let's pretend your affected knee is the left knee, and so we're actually going to start on the right knee. So I have them stand up. You can support yourself on my wrists, and then let's have you stand on the right leg only, and then just bend your knee to about 20 degrees. Good, and then go ahead and just twist back and forth with your upper body on your knee. Good, and then does that hurt at all in the knee? No, okay, and then we'll have you repeat the same thing on the left. Go ahead and bend about 20, good. Any pain there? Okay, no. So for Thessaly, it would be positive again if they have joint line pain, it reproduces their typical meniscus type symptoms. I mean, patients with patellofemoral arthritis will probably hurt when you do that test too. So it's not totally specific, but it is actually more sensitive than the McMurray. I think those were the exams I was going to highlight, and then I'm happy to take some time for questions. Carlin, do we have time for a couple of questions?
Yeah, we have a good amount of time for questions.
Okay, great. Yes.
So for an acute injury, when's the best time to examine the patient? How days after, or to get the best result or the best prediction?
Sure. So the question is, if somebody has, say, an acute knee injury, when is the best time to examine them in terms of getting the most information out of the exam? Sure. So a lot of us do sideline coverage, right? Like I do a lot of football sideline coverage. So I would say sometimes if you can get to them right away before all the swelling and the stiffness and the guarding happens, that is pretty ideal. But if you can't get to them right away, then I would just say, if you're worried they have an effusion, it really was an acute injury, or the patient feels unstable, or they might have locking in the knee, then I would just say any time is fine. Just because you'd want to screen them to see if it's something where you think they might need an urgent MRI or need to come in to see us. But usually I would say the most accurate exam is either right away before there's swelling and guarding, or like say for an ACL tear patient, you get a more accurate exam with, say, pivot shifts, something like that, if they're at least a couple of weeks out and the swelling and the acute pain has gone down. Yes?
Do you think it's reasonable to limit to 1 or 2 exams per area? Like for example, if I feel a patient can do a Thessaly, I typically won't do a McMurray because the Thessaly is more sensitive, or do you typically do all of the exams all the time?
Sure. So how many of these exam tests do I do all the time? Yeah. And then one other thing on that note I wanted to point out is we do sometimes at these courses get questions about, hey, if I have a patient with kind of a suspected or known history of knee arthritis, do I do all those tests? No. Okay. I'd probably even skip Thessaly, maybe even skip McMurray, more just testing ligaments and range of motion and just how large of an effusion they have. Yeah. So there are definitely times where I'll skip quite a few of these exam tests, but I'd say my average patient where I'm really suspicious from just their story and their age that their problem is probably, say, a meniscus tear. Then I usually do at least half of those physical exam tests. But as you said, if they're sore and 2 of them have already been positive, then sometimes I will skip the others, especially like Thessaly or Apley, because you have to have them in a different position. But this is sad, but with insurance these days, sometimes to get an MRI authorized or for us to get a surgery authorized, sometimes there are checklists that the insurance reviewers will go through where they literally won't authorize an MRI or surgery if the patients don't have, say, 2 or 3 or more positive tests for meniscus. Yes.
What is the ticking test? I didn't understand what you were doing with the ticking test. It was some way of palpating the patella.
Oh, sure. The milking test.
Well, there's a milking. Then you said something about feeling a ticking or something.
Oh, I see what you mean. The ticking test. Yeah. So I call it. It is called like the milking maneuver, or the milking test, where you're milking fluid under the kneecap. And then I call it a tick. So what happens is if there is fluid that you've collected under the kneecap and you're still sort of supporting the kneecap on that fluid, the kneecap is literally floating over the trochlea. And then when you, with your other hand, kind of push down intermittently on the kneecap, you'll feel this ticking. It'll go tick, 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 and the patient sometimes can feel it too. It's a way to convince them that they really have an effusion and need to stop playing soccer and need to go get their MRI. So I call it ticking, but you'll feel it and hear it go tick, 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 tick with the undersurface of the patella hitting the trochlea. And then you can always compare to the other side, and the other side usually it's negative. You don't feel any ticking. Yes?
In a high school athlete who has signs of meniscal injury, when do you decide to have them go straight to PT versus getting an MRI first?
Sure, good question. So say a high school athlete that they have acute onset of pain and you're suspicious from their story and potentially their exam that they might have a meniscus injury, when do you get an MRI?
Versus just have them go to physical therapy.
Versus just have them go to physical therapy. If they're a pretty high level high school athlete where they're playing every day, and you really suspect a meniscus injury, I usually get an MRI early, especially if they have an effusion and they have multiple positive physical exam tests. My reasoning is there are some meniscus tears where where I would definitely want to think about surgery earlier, and where I'm just not that confident that physical therapy is going to resolve their pain enough. But then there are other times where we get the MRI back and say it's mostly a horizontal tear or a small radial tear. And some of those, then I would be okay with them trying physical therapy first. So especially if they're going to keep doing high-risk things for further tearing in the meniscus on a regular basis, I would lean towards getting the MRI early, ruling out a bucket handle tear, a flap tear. They usually wouldn't have a root tear, but just a radial tear. Those tears actually don't do well over time. A root tear is essentially like a type of radial tear. So if they had a large radial tear, I would actually want to fix that because that would help prevent knee arthritis. So I'd say I'm fairly aggressive ordering MRIs on, say, high school athletes. Or how about you, Carlin?
Yeah, I would say, yeah, totally agree. It's interesting. The studies that I presented are adults. And I don't think we have similar studies for kids yet. And I agree with Ellie, like my red flag is really a fusion. I always tell the residents who work with me in clinic, like if I had like a magic wand and I could give you a skill upon graduation for your exam skills, what would it be? It would be, can you detect an effusion in the knee? Because it's such a good red flag. Like if you can detect an effusion with confidence, if I see one of my high school kids, one of the WASH kids, and they come off the field and they have an effusion, they're not going back in the game. Got to get imaging, got to see what's going on. And I start with an x-ray. But, if I do an exam and I'm worried about a meniscus tear, I would get an MRI too on a high school kid.
Yes.
You mentioned this entity called pes bursitis, and I when I'm palpating the knee, I'm palpating the joint lines, and then they get this pain in the medial aspect, and I'm thinking, there's nothing there. But you're telling me there's an entity called pes bursitis?
There is, yeah. So I can show you, it's a little hard to see, it's small, but on the knee model. But yeah, this would be, say, the kneecap. So this is the medial knee. So here's the medial joint line. And then there is this little kind of ridgy prominence, almost like the equivalent of Gertie's tubercle laterally, where the medial hamstrings come and insert. And there is a little bursa on there that's usually deflated and flat, but sometimes that bursa can get inflamed. So I've actually had it where I've seen visible swelling there, or even a little bit of kind of redness and irritation. So if they're tender below the joint line, you're really confident they're tender over the anteromedial tibia, then I would want to think about pes bursitis. And then the treatment options for that's different, right? You might adjust physical therapy a little bit. Some of our primary care sports medicines will actually do ultrasound-guided cortisone or Toradol injections into the pes bursa instead of into the joint to help calm that area down. Do we have time for one more question,
Yeah.
Carlin? Oh, okay, great. Yes.
The acuity interpretation, you review the qualifications for joint infusion versus just inflammation. Is it just a body kind of tenderness in the soft tissue, or specifically that same thing on the joint line? Where do we draw the line between joint infusion on the palpatory examination and just inflammation?
And just inflammation, sure.
Yeah,
Carlin,
I think I would think about like a patient with patellofemoral pain. You may notice a patient with patellofemoral pain has like a lot of soft tissue fullness. Sometimes the knee will look kind of puffy, but then you feel the knee and you can't swish the fluid around. I think about an effusion a lot like a water balloon. It really feels like as Ellie was saying, you can kind of swish the fluid, and I'll put one hand on top of the patella and one on either side of the patella, and you can kind of swish the fluid back and forth. Same way you would with like a fluid wave in the belly, just swish back and forth. So it's really that. It's like, I don't find it very helpful at all to like inspect and decide based on my inspection if there's an effusion. I like the patient and I don't bother checking at all when they're sitting. I like the patient lying down, and then just carefully feeling, and do I feel that there's swishing inside the knee, that there's fluid swishing around? Okay, thank you so much. I think we're going to switch. So thanks, Dr. LaRoque.
Thanks, Carlin.
All right, so it's my pleasure to introduce Dr. Stephanie Wong. So Dr. Wong is an orthopedic surgeon and sports medicine specialist who cares for patients of all ages and with hip, knee, and shoulder injuries. She earned her medical degree at UC Davis and did residency here at UCSF. She completed her fellowship at Rush. And after fellowship, we were lucky to have her come back home here to the Bay Area and to join our department. Dr. Wong's clinical practice is here in San Francisco as well as at the UCSF Berkeley Outpatient Center. She's a team physician for Lowell High School. Any Lowell alumni in the crowd? Yes. As well as the Cal Bears. Any Bears alumni? Some, yes. Dr. Wong's co-medical director of our UCSF Women's Sports Medicine Center. She's leading the research efforts of this team. She's an awesome teacher. She's director of our UCSF Sports Medicine Surgical Fellowship. And clinically, she has advanced expertise in hip arthroscopy for hip preservation, the treatment of hip labral tears and hip impingement, and in the use of patient-reported outcomes to guide decision-making with surgery. Lastly, in the spirit of welcoming everyone to the Bay Area, I asked today's speakers to share with me a restaurant recommendation. Dr. Wong recommends Rintaro. Has anyone been to Rintaro? Yes. Rintaro is quite delicious. It's a fantastic Japanese restaurant whose highlights include handmade udon made daily and Half Moon Bay wasabi. So I think you should check it out. You should make a reservation, though. So today, Dr. Wong's going to talk to us about the top 5 hip problems in primary care. Please join me in welcoming Stephanie Wong.
Thank you, Carlin, so much for that kind introduction. And I'm really excited to get this meeting off to a fantastic start and excited to see everyone's faces here today. All right, let's jump right into it. These are my disclosures, not particularly relevant to today's talk. So in terms of objectives, I really want you to come away with being able to identify common causes of hip pain, determining proper diagnostic modalities. So if you see this patient, understanding when to order what tests, and then understanding a bit about non-operative and operative treatment options, and then recognizing kind of when to refer to us as kind of hip specialists and orthopedic surgeons. All right, so as realtors always like to say, location, 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 so important. And I like the hip a lot because a lot of the pathology you can kind of narrow down your differential based on where the location of the pain is. So if you think about the hip and the pelvis and general anatomy, a couple different locations that I like to point out, and this of course oversimplifies things, but if the patient has anterior pain or pain in the groin, there are a couple different musculoskeletal causes, and they include femoral acetabular impingement, hip arthritis, avascular necrosis or death of the femoral head bone due to lack of blood supply. Stress fractures are really common in this area, though can happen in other parts of the pelvis. And then slipped capital femoral epiphysis, which is like a physeal fracture of the femoral epiphysis in pediatric or adolescent patients. So that's really groin or anterior hip pain. And we'll go through some of these soon. When you have lateral-based hip pain, really the structures that are there in terms of musculoskeletal pathology include the trochanteric bursa, IT band, as well as gluteal tendons, which can either be torn or have tendinopathy. And then finally, if a patient tells me they have hip pain, but then they point to their low back, that's either I'm going to refer them to my spine partner, or it could be an SI joint issue, or if it's lower down kind of in the sit bone or buttock region, we think about also kind of proximal hamstring. And so I just want to keep all these in mind. I think sometimes the hip can be a little bit intimidating, but if you kind of say, I ask patients, where is your hip pain? Show me. And then have them try to use one finger to point. And then if they point to one of these areas, you can start kind of narrowing it down. Okay, so just showing a case. This is a 34-year-old, maybe former fellow, who presents with groin pain for the past year, former college basketball player. No specific injury. He has worse pain with sitting, squats, basketball. He also does some CrossFit on the side when he's not at work. He has some limited motion in his hip, but it's kind of mild. So this is kind of the classic presentation for patients that have femoral acetabular impingement or hip impingement. And what this pathology really is it's often chronic, so no specific injury is described. affects a really broad range of patients from kind of adolescence up to middle age. And what happens developmentally is you have abnormal repetitive contact of the femoral head-neck junction up against the acetabulum. And as a result of this, you actually get abnormal bony remodeling. So there'll be a bump that develops on the side of the femur in CAM-type deformities. And with repeated kind of force, then you'll eventually develop labral tears, subsequent cartilage injury in the hip joint, ongoing joint inflammation, and this unfortunately predisposes people to osteoarthritis, with 50% of early OA cases meaning that you have significant OA before age 50 due to FAI. And this is let's see. That was going to be a diagram. I don't know how to get it to play, but that's all right. This is a view from inside the hip joint looking at the labrum. So the labrum is a soft tissue kind of bumper of fibrocartilage that helps to provide kind of a suction seal and helps to contribute to hip stability. You can see here the probe that I have is kind of in the labral tear, and you can see like a little flap of cartilage down as well. So that's what happens when you have kind of this bony remodeling. It results in this. Labral tears are exceedingly common. How many of you have ever seen a patient or ever ordered an MRI that reported on a labral tear? Like most of the room, okay. So present in over 90% of patients with FAI, so to the point where we often debate, do we even need this? If you see like significant FAI on x-rays, we still get the MRI for pre-surgical planning, but we kind of know what it's gonna show. We know it's gonna show this. And I like to quote this other study a lot. They MRI'd a bunch of asymptomatic patients in their 30s, and 70% of them had a labral tear. Asymptomatic. So if your patient has low back pain and they come in with an MRI and they say, but my labrum's torn, I need a surgery, I think do try to distinguish if they have groin pain, do they have the appropriate physical exam maneuvers, do they have the whole clinical picture, or is this an incidental finding of a labral tear and it's not clinically significant? Some labral tearing without bony abnormalities can be just degenerative. So think about your degenerative shoulder labral tears in patients over 50. Think about your degenerative meniscus tears. Sometimes you see them in patients don't even have pain or meniscus findings in that compartment. So similar also in the hip. Okay, so I'm showing some pictures of some athletes here. Does anybody know what these athletes have in common besides making a lot of money? Yeah, good. So they all had hip arthroscopy for FAIS, which is femoral acetabulum impingement syndrome, which describes a clinical presentation. Really, really high prevalence of FAI in our athletes. This study showed 90% of patients in the NFL Combine had at least one sign of FAI on their x-rays. 75% elite youth hockey players with FAI. This data is reproduced in other sports as well, so elite and professional soccer, et cetera. So it's really an adaptive finding. I think the more active you are playing sports, kicking, et cetera, this is how you develop this condition. Okay, so the clinical presentation, patients will describe anterior hip pain. They'll kind of point at their groin, they'll take their hand, and they'll do this without being prompted. They'll say it hurts in this distribution. We call that a C sign. And it tends to be worse with sitting. So sometimes they'll say it hurts when I sit on the plane for a while, it hurts when I sit in the car, or it hurts when I'm doing sports and activities. It doesn't tend to hurt them nonstop. So I think for patients that have really high levels of pain, severe pain, constant, that's probably not this presentation. On exam, which we'll go over in a second, they'll have a positive flexion, adduction, and internal rotation exam maneuver, which is my favorite test because it says in the acronym what you do to do that test. And they often will have limited hip internal rotation, and it's subtle. It's like 5, 10, 15 degrees. It's not like, 30, 40 degree difference. So it is really subtle, but I'll show you how to check for that. This is a video looking at the scour test, which is a different physical exam maneuver similar to Fader, which I'll show you live here in just a moment. So in terms of imaging, so I think this is why it's so important, in my opinion, just to get some basic x-rays. So if people come in with joint pain, they don't seem to be responding to some conservative managements, maybe they tried rest, NSAIDs, some PT, get x-rays, because I think it'll really kind of help understand, is this arthritis, yes or no? Is this FAI? So you can kind of see here on this slide how there's those bright green arrows pointing at this big bump on the side of the femur. You can see how there's like a bony edge or prominence. So that is the abnormal deformity. And then on the lateral view, you can also see kind of a big bony prominence there. The head should be more round and it should taper off to become more narrow at the neck. So that is consistent with femoroacetabular impingement on imaging at least. MRIs will often look like this, where you can see that black triangular shaped structure. That's the labrum in cross-section. And you can see there's a linear line of fluid going between the labrum and the acetabulum. So that clearly demonstrates the labral tear. Okay, so with treatment of FAIS, I always recommend a trial of non-operative treatment. The literature does support it. And really it's focused a lot, and I say this, I think the residents and fellows are so sick of me saying this, but I'm like, core and glute strengthening, Pilates, PT, pelvic stability stuff, I think so important for anything lower extremity, but definitely for the hip patients. So these are some of the exercises, that you can think about. You can also consider intra-articular injection. So I think this is really nice for patients who have a lot of pain with daily activities, not responsive to oral medications such as NSAIDs, or they feel like they have too much pain to actually make good progress with PT, or they have lots of pain in lots of places. This helps differentiate if the labrum is actually the cause or not. So if they come in with lateral pain, groin pain, low back pain, radicular pain down their leg, and you're like, I don't know what is actually bothering you, or if it's multiple things, I think an intra-articular injection can be really helpful. So either steroid, ketorolac or toradol, or platelet-rich plasma can all be options. This is just an example of an ultrasound-guided intra-articular injection. In terms of surgical treatments, I just wanted to share with you, in case you are curious or knew anyone who's had this surgery, some just photos of our intraoperative view of the hip. So you can see here on that far left-hand photo a picture of the torn labrum. And then we use suture anchors to repair it. So this is similar to other labral tears in the body, but basically sew the labrum back up to the socket. And then this was a 16-year-old football player's hip, but he had a big kind of bump on the femoral head. So what I'm gonna do is use this spur, which looks ginormous in the picture, but it's like half the width of my pinky. So it's small, 5 millimeters. But we're gonna use that to reshape the bone so it's more smooth, get rid of that bump on the side of the femur. And so that's kind of the finished result there. In terms of whether to do surgery or PT, I think the data is really interesting. There are multiple really well done, large randomized control trials that show that both PT or non-operative groups and surgical groups do improve over baseline. The surgery group tends to improve a bit more, which I think is fascinating. So on this graph, for example, you can see how the hip arthroscopy group in that top red line, by 12 months out, they're exceeding outcome scores compared to the non-op group, but both groups are improving over baseline. So I just keep this in mind. I do think a trial of non-operative management is still indicated in patients. I think most patients, probably 70 to 80%, do not go on to surgery. And as Ellie mentioned, unfortunately, insurance is always a big part of our lives. You do need to try non-operative care before they will approve any surgeries. Okay, so why do we care so much about FAIS? I just told you that a lot of people have labral tears. Some people don't have pain from it. We care because if you look at this x-ray, it looks kind of similar to that first one I showed you, right? Except more arthritis changes. So joint space narrowing, sclerosis, more osteophytes. So if untreated with the labral tears and chondral injury, we know this can lead to hip arthritis. And early onset hip arthritis is about 50% due to FAI and about 50% due to hip dysplasia or a shallow socket. And those are the conditions we usually screen for in childhood or infancy. But occasionally people have such mild forms that they'll make it all the way to adulthood without having symptoms or without really being diagnosed. This is our longest term follow-up for hip arthroscopy and labrum surgeries, which is not that long. It's 12 years. Compared to knee arthroscopy, which we've been doing since the 70s, not me, obviously, hip arthroscopy really has only been done since like the early 2000s. So it's actually a relatively new procedure, just technically more difficult, hard to get into the hip joint without traction, instruments needed to be longer, et cetera, so some technical things. This study showed that at 12 years, doing hip arthroscopy did seem to reduce the risk of developing arthritis, at least on x-rays. They did not have patient outcomes, so hard to, extrapolate this, and this is one surgeon's set of patients. I think more data to come over time in terms of long-term outcomes. But yeah, I think this is interesting. Okay. Moving on to a different condition. This is a 60-year-old male who presents with worsening atraumatic anterior hip pain for the past couple years. He is limping. He says, I really want to play pickleball, but I can't keep up like I used to. And he's having some trouble putting on socks and shoes. So this is kind of a nice way to present with osteoarthritis, hip osteoarthritis specifically. And again, this patient, if you look at his x-rays, he probably had some femoral acetabular impingement syndrome back in the day, because if you look, you see kind of that femoral head morphology. But on these x-rays, you see joint space narrowing, sclerosis, osteophytes, and those are kind of the cardinal findings of arthritis. Typically involves people 50 and over, although sometimes you can be surprised, so always get an x-ray if you're not sure. Chronic groin pain, usually not acute, and they'll describe achiness. They'll say it feels stiff. They'll have some difficulty walking distances, very short distance, and sometimes in late stage, and they'll have difficulty with shoes and socks primarily due to the lack of ability to do rotation in their hip, like I said, for the exam. And then, as we mentioned on the x-rays. And then just for your comparison, this is a normal hip. So I would say, I always encourage people, if you're ordering x-rays as a primary care physician, don't just read the report, actually pull it up and look at it for yourself also, because I think it helps just to understand, I don't know, I think a picture's worth 1,000 words, and you have to look at a lot of normals to understand what exactly is abnormal on the opposite film. So yeah, and then for hip osteoarthritis, we trial a lot of non-operative management first, including things like NSAIDs, injections, PT, and weight loss, which are all evidence-based and supported by our American Academy of Orthopaedic Surgeons as non-operative treatment guidelines. So the PT program, pretty similar. Another image of injections. Now for hip injections, you do need to have an image-guided modality. So either fluoroscopy or ultrasound, just to be safe, because it's near the femoral neurovascular triangle, and also to make sure you're actually in the joint. So either one is fine. And then I think weight loss also, we'll get to a slide on this in a moment, but also really important to think about as well in terms of how much load we're putting through the joints. So hip replacement is a surgical treatment for hip arthritis. And this is what it looks like. I think a lot of people are probably familiar, but it's a metal stem with a metal ball, a plastic liner, and then a metal socket. There are some other variations of this, including ceramic components, which are a little bit harder, more durable. And that's kind of what it looks like on x-ray. And as you can see from this graph, which actually encompasses both total knee and total hip replacements, you can see this kind of increase in number of procedures over the past decade or so. So I think as our population ages and as these implants become more and more available, you can see in terms of numbers like millions and millions of people. Okay, in terms of hip replacement outcomes, really excellent outcomes overall. It's probably the most successful orthopedic surgery that we do. 90 to 95% of patients achieving minimal clinically important difference. All right, hopefully everything's okay. That half of the room looks much more alarmed than this half of the room. Survivorship for hip replacements is actually quite good. So I think in the past, people used to say, don't get a hip replacement, they only last 10, 15 years. My hip replacement partners would disagree with that nowadays with improvement in implant materials. Patients that I have who have arthritis at a young age, maybe they're 45, they'll say that if you use this hip judiciously, AKA maybe don't gain a ton of weight and don't pick up ultramarathon running as your only hobby, they can actually live with that hip their whole life and have it survive the whole time. But I think outcomes really are excellent, and this is kind of the survival rates over years. Very rare but significant complications when they do happen, such as dislocation, fracture around the prosthesis, or infection, which is a big, big deal. So I think significant, but again, many, many millions of people worldwide living and very happy with replacements. So really has revolutionized our treatment of arthritis. How many people either know someone or have prescribed GLP-1s? Yeah, so I feel like almost the whole room. So I think, they're really interesting in their role on arthritis. So obviously they have an effect on things like weight loss and control of other diseases, including type 2 diabetes. But interestingly, they also may affect the joint environment in osteoarthritis. The joint environment is typically very pro-inflammatory. So if you take synovial fluid from a hip joint, there'll be all these pro-inflammatory markers, and that we think that that's why people have pain from arthritis. GLP-1s may actually modulate that inflammatory response, so it may actually like treat some of their pain. It does seem to improve pain in an osteoarthritis mouse model. And so the question is, could this be something like a disease-modifying arthritis drug? Maybe. One of the main issues I think with this, as many people have seen, is that patients do lose a lot of weight. We don't know what happens when they come off of these meds. We don't know what happens when they're on these meds for a really, really long time. We also don't exactly know when they lose weight, what proportion of weight they're losing. Is it a lot of fat? Is it all muscle? Is it equal proportions? Is it different for different people? So there's this concept called sarcopenic obesity that we also talk about, where patients may not have a lot of muscle, but they're very overweight. And we don't want them to also then continue to lose muscle mass. So just a lot of, I think, promise, but also some questions in terms of long-term how it's going to affect our patients. Okay. So going on to a different case. So this is your uncle, water skiing at a local lake. He fell and says he has immediate hip pain, heard something about hips, so gives you a call, can't walk, notices a lot of bruising in the thigh, and calls you to ask what you think is going on. So unfortunately, he has a proximal hamstring injury. These are typically acute, can sometimes be chronic if they're more of like a tendinopathy or partial tear. They usually describe an awkward fall. So people say, I was water skiing, I did the splits, or I slipped on wet floor. Not really around here, but in my fellowship, which was in the Midwest, people would slip on ice sometimes and they had this injury. Lots of bruising, buttock pain, pain with sitting on the sit bone. They'll look like this. And if you see them acutely, you'll see really a dramatic, amount of bruising and ecchymosis. If it's later out, like 3 months plus later, they'll usually pull out their cell phone and show you a picture. Yeah. Tenderness usually over the ischium, weakness with knee flexion and hip extension, which are the actions of the hamstring muscle group. I always get x-rays on these just to rule out a bony avulsion, so ruling out that they pulled a piece of bone off the bottom of the pelvis on the ischium. And then the correct MRI order is the MRI of the hamstring or femur, depending on your institution. If you get an MRI of the hip, it may not capture this because the hip MRIs usually stop at the proximal femur. And if the tendon's retracted past that, you won't capture it actually. So you want to MRI the whole thigh for this injury. Non-operative management we'll talk about in a moment, but can be considered with NSAIDs and PT, and then the operative surgery is proximal hamstring repair. So outcomes after surgery are interesting. Usually for acute repairs, patients have high satisfaction, low re-tear rates, good outcomes, but the complication rate's kind of high. It's like 20+%. I don't know about you guys, but I don't like to do anything that has 20% complication rates. Acute repairs seem to do better than chronic conditions. The quality of the study is overall generally low until this study came out in 2024, which is actually a nice study showing it was a randomized controlled trial randomizing patients either to surgery or non-operative treatment, and then they also had an observational cohort for those who didn't want to be randomized. Wide range of patients, mostly acute injuries, all full thickness, 3 tendon tears. And then if you look at the graph here, the operative line and the non-operative line, see how they look essentially the same? This graph is kind of depressing as a surgeon. It means that like if they didn't do surgery, they did the same, and then if I did surgery. And then the score, which again, maybe is not the best name, but called the FAT score, which is a patient-reported outcome score for hamstring, did not show any significant difference between the two groups. So I think, this study had them doing very specific hip PT. So I think the takeaway is that they can do really well with non-op treatment, but non-op doesn't mean no treatment. It means like a focused physical therapy plan. These are some images from an open proximal hamstring repair, just so you can see what it looks like. This is, the incision is across the bottom of the gluteal crease. The tendon looks like this. We put some sutures through it and then reattach it to the ischium with suture anchors. And there's not that many surgeons that do this surgery, mostly because it's kind of scary. You see that yellow squiggly looking thing to the right of the tendon on that bottom picture? That's the sciatic nerve. So it's close by to the field. It kind of stresses us out. If we don't do the surgery well, sometimes people can have sciatic nerve, kind of neuropraxia, nerve irritation, at worst, something like a foot drop. So, I do talk to patients about that really carefully, make sure they understand, the risks with this procedure. And the recovery is really, really tough, even for your young, sporty patients, young for this injury being like under 50, 55. 6 weeks foot flat in a brace, crutches and a walker, usually PT for over 6 months typically to get back to kind of sports. Sports a little bit longer. This was a study we did just on a kind of novel accelerated program to get people through their recovery. We looked at a group of our 21 patients. We actually braced them with their hinge knee brace locked in extension. A lot of people for hamstrings will brace them with their knee flex because you'd think, okay, that takes attention off the hamstring, but nobody likes to walk around in a brace like this for 6 weeks. I mean, how horrible. So we've shown that basically high patient-reported outcome scores, low pain scores, high satisfaction, and no re-ruptures, reoperations, or infections in our group. So I think this can be applied and is generally safe, but it's an alternative to the knee-flexed bracing position, which a lot of people use historically. Okay, let me just check the time here. Okay, I think we're doing okay. All right, so let's talk about a different patient. So this is a 45-year-old female presenting with also, again, anterior hip pain. So think back to that diagram where we looked at all the different diagnoses. Pain for 3 months, doesn't recall any specific injury. She's very active, loves running, training for a half. She likes to eat clean, she tells you, and she really wants to get back as soon as possible. So please tell her what's wrong so she can get back to her training program. She doesn't want to fall too far behind. So this patient will be most worried about a stress fracture in. So again, high loading activity, patient who may show some signs of maybe disordered eating or eating patterns. Stress fractures can occur in the femoral neck region as well as the sacrum and other parts of the pelvis. The pain typically localizes to that region. So around the femoral neck, it'll localize anterior, sacrum, obviously posteriorly over the sacrum. And then the things I like to check for, increased loading. Are you doing impact activities? Do you have any history of disordered eating or being really kind of restrictive with your diet or insufficient fueling? And then do you have a history of stress fractures, actually the most predictive thing that's going to increase your risk for stress fracture in the future? So you can just simply ask them that. And you can look at this in more detail in your syllabus, but basically these are some of the modifiable, non-modifiable factors that can play a role kind of in this condition. So the clinical presentation is usually, they may have an antalgic gait. If the bony surface that they're injured is superficial, such as like their foot or the sacrum, they may have tenderness on palpation, and they will have pain with loading activity. So if they have a normal gait and you can't elicit any pain on their exam, what you could have them do is a single leg hop, and I would have them do it on both sides. If they're really painful with a single leg hop, then for that person, that would be like rule out stress fracture until further notice. I would caveat by saying probably people with really bad OA also have really bad pain with single leg hop. So if their hip x-rays look normal, they've been loading a lot, then I would think about this. Again, x-rays often normal. Low threshold to get an MRI in these patients, and then I would have them hold off on impact activities until you get that MRI. And these are the ones I would order as urgent. This is a picture of a femoral neck stress fracture in a runner. You can see all that white bone marrow edema, and then the gray is normal on this sequence for the bone. This is a progressed stress fracture, so you can see how there's a black line now within that white edema area. So if that line goes all the way across the femoral neck, then this patient has a displaced femoral neck fracture, which in a young person is a devastating injury that can result in like an early hip replacement. So these are really critical to diagnose and not miss. And then this is a picture of like a sacral stress fracture. So the order that you would get for patients with more pain over the sacrum would more be like an MR of the pelvis rather than the hip, depending on the location of their pain. In terms of treatment, offloading rests at least 4 to 6 weeks. So I put most of these patients on crutches and then a gradual slow return to activity. So that starts with walking and then low impact stuff. So like elliptical stationary bike, running or impact really like 3 months plus out from their diagnosis. If still painful, I like to check for their compliance and also make sure I'm referring them to my colleagues for bone health workup, nutritional evaluation, et cetera. But those are the patients I would consider doing surgery if they're failing non-operative care. You can try continuing to offload for a few more weeks, but at that point, screw fixation for especially femoral neck fractures, which are the most kind of structurally concerning, is the surgical treatment for this. So we place cannulated screws similar to how we fix femoral neck fractures, just to help stabilize the hip. And again, I think bone density, workup, nutrition consult, and then a loading assessment is great. And I'm lucky to work with a lot of primary care sports medicine docs who can help us with this as well. All right, we're getting towards the end. So one more case and then we'll do some physical exam. This is a 67-year-old who you've been treating for over 6 months, coming in with lateral hip pain. So remember back what was on the lateral side of the hip. She's limping. She doesn't seem to be improving with non-operative care. She uses this cane. She did try some PT. She was pretty good about it. She's had 3 prior corticosteroid injections to her trochanteric bursa. They seem to help. She's coming back asking for another one. And this patient has what we call greater trochanteric pain syndrome, which is really a constellation of different symptoms, including bursitis. And the bursa is a layer underneath the IT band that's like an internal cushion that can get inflamed and irritated. And you have these all over your body, in the knee, and the shoulder, and then the hip and elbow. The IT band can also be really tight, which can cause inflammation and friction over the bursa. And then gluteal tendons attach on the greater trochanter, so those can either have tendinopathy or tearing. And then finally, some people will describe like a snapping sensation, or they'll tell you, sometimes I have patients tell me, look, I can dislocate my hip, and then they kind of like maneuver their hip around, and it's just their tight IT band kind of snapping over the trochanter. So sometimes you have that as well, which we call external snapping hip. So gluteal tendon tears, I refer to these as rotator cuff of the hip, because a lot more people are more familiar with rotator cuff pathology, but it's really the same thing. Tendon is a watershed area, and with aging and with use, we can get some degeneration, tendinopathy, and finally tearing. This is an MRI showing the greater trochanter, and you can kind of see that white area where the tendon doesn't attach down, so it's a gluteal tendon tear. Can be acute or chronic, usually more present chronically. Usually females in their kind of 50 to 70-year-old age group is the most common group that has this injury. And they usually describe both pain as well as weakness. I think weakness really differentiates it from bursitis alone. And we'll show you this on the exam, but weakness with abduction. They'll also have a positive Trendelenburg sign, is where you have them stand on one leg and then their pelvis drops on the opposite side because the tendon cannot help to support or level their pelvis. We'll show you that as well in a moment, but this is a diagram. So if you have them do a single leg stance, they should be able to keep the pelvis level. If you have them stand on the affected right side and their opposite pelvis drops, that means that they have a gluteal tendon tear on the right. And this is looking at them from the back. And again, can coexist with trochanteric bursitis. In terms of treatment, I think, again, same thing. Physical therapy, injections we think about, IT band, rolling, stretching, etc. Injections can be landmark-based. You can do these in the office. I would caution, though, not to repeatedly inject. So this patient is coming in asking for a 4th injection. I would do 1 or 2 max. If they're not improving, that's the patient who's getting an MRI just to rule out a tendon tear. If you just keep injecting, the concern is that the tendon quality will degrade over time, and you're maybe just masking a gluteal tendon injury. In terms of surgery, we either do open or endoscopic repairs of these injuries, similar to rotator cuff. Rehab after that surgery is similar to rotator cuff, except that it's hard to be non-weight bearing on a leg compared to a shoulder, but pretty long recovery, 6 weeks off of it, and then about 6+ months full recovery. I just wanted to highlight this study. It's a study that we collaborated on with our primary care colleagues at UCSF. It's in press right now, about to be published, but we looked at ketorolac versus corticosteroid, because there's a lot of patients who are concerned about kind of steroid around joints, around tendons. Maybe your patient has, diabetes and they can't get a steroid injection. So ketorolac is a nice alternative. In our study, we looked at either ketorolac plus local anesthetic injections or dexamethasone plus local anesthetic. We treated patients with hip OA, FAIS, extra-articular tendinopathy, so hamstring, gluteal tendon. And both groups had significant improvement in pain and symptoms. In the hip arthritis group, the ketorolac group actually had more relief, and there was no difference in duration, effect, or onset. Onset was usually about 5-ish days, and duration of effect was about 3 months in our study. So I think this is a nice alternative. Again, do screen for kidney disease or allergies if you're considering ketorolac referrals. But I think, has been used intramuscular and IV for decades, so a safe application around and in joints as well. Okay, I'm going to go through this quickly just so we have time to go through our exam, but these are just some images showing a gluteal tendon tear and then an open repair, which we do with suture anchors, which are these sutures sticking out from the side of the hip, and then kind of sewing the tendon back down to the bone. And then just briefly wanted to talk about trochanteric bursitis. So this is an inflammation problem without a gluteal tendon tear. Again, common in the similar patient age range. They usually have pain over their lateral hip, and they'll often describe pain when they lay on that side. And they should not have any weakness. So if you have them do hip abduction, you have them do a Trendelenburg, they should be able to give you full strength, and their pelvis should stay level with a single leg stance. This is a picture of bursitis, so just a lot of inflammation over the lateral side of the hip, but the gluteal tendons look intact, so the black tendons connecting down to the bone. Most of the time we can treat these non-op. There are very few that end up going on to surgery, but again, similar treatments to the gluteal tear group. For those really recalcitrant cases, you can do an endoscopic bursectomy and an IT band lengthening. And then in the interest of time, I'm just gonna go through this. I'll skip through this, but essentially IT band also kind of along the same picture and similar treatment options. And then just quickly wanted to show you some pictures of an endoscopic IT band release. So we're working here on the outside part of the hip, outside the trochanter. And these endoscopic pictures are making an opening actually longitudinally in the IT band. And then we actually do kind of a cross cut like this and then make a diamond shape. So we're actually windowing the IT band just so it isn't so tight and causing so much friction. And then removing all the bursitis underneath that. And then you can see the gluteal tendons and musculature underneath. And then we just leave it open, close the skin, but leave this window in the IT band open. So that's the surgical treatment for this procedure. Okay, I think that's all I have in terms of the lecture. Thank you very much. All right, and then next we'll move on to the exam, and then we'll do some questions at the end if that's all right with everyone. Hi, how are you? Good to see you. All right, so for the hip exam, we have Alan here. So thank you to him for volunteering to be our patient model today. So the first thing I do in terms of the hip exam, and you're dressed in the perfect outfit, thank you, is get them into something where you can actually move their hip around. So this is like not tight jeans or like really short skirts that are like awkward and people are uncomfortable. Like loose fitting shorts are perfect. And then what I'll have you do is let's start with you laying flat on your back. So you can put your head here and your feet that way. And then I'm gonna come around to the back actually. And so what I'll do for demonstration purposes is stand on this side, but what I do actually in clinic is I'll stand on the side that's closest to the injured side or symptomatic side. But I'll stand over here just so you guys can see. So the first thing I do is tell them, I'm gonna move your hip around, you let me know if it hurts, okay? And so what I'll start by doing is a simple log roll test. This is a really easy test, and it gives you an idea of how painful the patient is. All you do is you take your hands and just roll the leg back and forth. And what that's doing is rotating the femoral head within the acetabulum. So, for example, if they have a hip fracture, severe OA, a septic hip, they're going to be excruciatingly painful with this test. So this is a nice one just to start with, just easy peasy, understand if they're painful. It shouldn't be horribly painful for more of the other chronic conditions. And then the nice thing about the human body is you have a lot of things on both sides. So if they only have symptoms on one, you can compare to the opposite side. Next, after the log roll, what I'll do is called a straight leg raise. So I'll have you lift this leg up in the air, hold the leg straight, perfect. Okay, so he's demonstrating to me now his hip flexion strength is at least anti-gravity. And this does do some axial load of the hip joint. And then what I'll do in this position is actually, I'm gonna push down, so give you some resistance. Good, you can relax. So testing his hip flexor strength, which is for me 5 out of 5 because he has good strength against resistance. Did you have any pain when I did that? Okay, good. So that resistance test we call Stinchfield, or if you don't remember the name or don't know it, you can also just describe it, resisted straight leg raise. Did not cause pain in him. It can cause pain in people with OA, with any sort of inflammatory process in their hip, so bad FAIS, for example. So I'll do that bilaterally. Next after that, what I'm gonna do is some range of motion. So I'll have you bend this hip and knee up. And so I'll kind of hold at their ankle, I'll guide their knee, and then I'll say, bring your knee in towards your chest. Good. And so I'm looking kind of at this angle. Actually, here, let me do it on this side for you. Good. And so if this is 90 degrees, then you can just say, and I just kind of eyeball it, but for me, this would be like at least about 120 degrees or so of hip flexion, which is normal in his age group. From the hip flexion, then what I'll do is rotation. So this will be external rotation coming in this way. So it's like in the sitting cross-legged position, for example. And if this is 0, you can look from the top and say, okay, he's rotating kind of past the 45-degree mark, so about 50 degrees of external rotation. And then go back to neutral so your brain can reset. And then you're gonna go this way for internal rotation. He has maybe about 10 degrees of internal rotation. And then extension I would call 0 because he can put his legs flat on the bed. Okay, so that's kind of the range of motion assessment. And then to be efficient from this position, usually what I'll do is take them straight into the fader test because they're already flexed up. Fader stands for flexion, adduction, internal rotation. So he's already flexed. You're going to adduct him or bring his knee in towards the midline. And then you're going to internally rotate. So this is a classic provocative maneuver for hip impingement or labral tears. Does this hurt? No, okay, good. I'll give you your leg back for a second. Then I would repeat it on the opposite side too. And again, for FAIS, you wanna look for subtle differences in hip rotation, and it may be like 5-10 degrees, so it's pretty subtle, so just practice and see if you can notice it for some of your patients. The other hip impingement test I like to do is called scour, and this is similar to McMurray's for the hip, but basically we're gonna sweep the hip through a range of motion, try to kind of capture that labral tear as the hip rotates. So go ahead and bend up one more time. So you're gonna start them flexed up, but you're gonna externally rotate, and then sweep the knee like you're kind of going in a clockwise fashion, so kind of, and then into internal rotation and extension. And you can do this kind of back and forth a couple times. And usually because most tears are anterior superior, like in this region, as you come to like the 2-3 o'clock position on the clock face, that's when they'll be sore. Any pain when I do that? No, okay, good. So that's called the scour test, another provocative maneuver for labral test or hip impingement. The next test I'll do in this position is I'll have you now bend your knee up, put your other foot next to your other knee, and then let this knee fall to the side, that way. Good, so this is the Faber position, so similar to fader but the opposite. So flexion, abduction, external rotation. This test is a test classically for SI joint compression on the contralateral side, so the left SI joint. But it can also elicit anterior groin symptoms if they have pain in the front. So I always ask them, like, where does this hurt? And I'll ask for the other tests as well, because sometimes you'll be doing fader and they'll be like, I have low back pain. And I'm like, does it hurt in your groin? They're like, no, okay, that's probably not your labrum. Okay, go ahead and straighten this leg out. Okay, so that's most of my supine testing. You can also do some palpation as well. So you can palpate along from the ASIS down the front to check the hip flexors. And then what I'll have you do, Alan, now is can you roll on your side and face that way? Okay, so next I'll move on to the lateral hip exam. And so I'll have them lay on their side, and then what I'll start by doing is just feeling the side of your hip. So feeling right in here, you're feeling right over the most prominent structure, which is the greater trochanter. So if they're sore or tender here, consistent with trochanteric bursitis diagnosis, and then you can also palpate going down the IT band to see if there's any tenderness there, and then you can also palpate proximal in the gluteal tendon or gluteal musculature as well. Next, what I'll have you do, Alan, is go ahead and lift your legs straight up to the side. I'm going to give you some resistance. So this is resisted hip abduction. Good, so he has 5 out of 5 strength. You can relax down. So if he came in with lateral sided hip pain, I would check that to make sure he didn't have a gluteal tendon tear. So I would give him 5 out of 5 for that one. Okay, next I want to show you guys Ober's test. This one is a check to see if the IT band is really tight. So what we'll do is go ahead and bend your knee. Great, and bring your whole leg back towards me, is how I usually tell patients. And then drop your knee down to the table. A little tight. So his knee is not touching down to the table, which means that this structure, the IT band, is holding the leg kind of up in the air a bit. So that would be a positive Ober's test or some tightness in the IT band. Really common in young athletes or people who, do you play sports?
I'm in track.
Okay, runs track. So consistent. Okay, all right, so that's most of my lateral hip exam. The next thing I'll do in some select patients, not everybody, just depends on where their pain is, but what I'll have you do is lay on your stomach if that's okay. Okay, perfect. So in the prone position, I'll do my hamstring testing, as well as if they have any like low back or SI joint symptoms, you can also palpate while they're prone. So what I'll do, Alan, if it's okay, is just feel up the back of your hamstring. So I'm gonna start down low, usually on the opposite side from the injury, and just feel up the hamstring muscle belly. If they have a proximal hamstring, like a tendon level injury, they'll usually be sore up high in the ischium, like the sit bone area and the gluteal crease. If they have a hamstring muscle strain, really common in track, soccer, football, they'll be sore in like the muscle belly area. So that's the differentiating factor. So soreness in the muscle belly, probably fine, doesn't need imaging, gonna get better in 2 to 4 weeks. Pain up high, pop, lots of swelling, bruising, can't walk, get an MRI. So then you're gonna feel like up high on the ischium to see if they're sore there. And then for hamstring strength testing, the actions are knee flexion, hip extension. So we're gonna test both of those. So go ahead and bend up this knee. Pull your heel in towards your buttock. Yep, pull really strong. Good, and again, I usually do the non-injured side first so they can see what I'm doing, and then just to compare. So that's great strength, so 5 out of 5. Go ahead and bend this knee one more time. And then kick the ceiling with your foot. So kick upwards, good. So hold that up really strong. So this is testing the hip extension, okay? All right, you can come on back down. So those are the 2 resisted strength tests for hamstring. Okay, great, and then can I have you stand up? All right, so the last part of the exam we'll do is in the standing position, and I really like to, number 1, see how they squat. So if you want to take 1 step out forward, maybe just so you have room. So just a regular body weight squat. Good, so Alan's demonstrating really good form. So he has like a stable base, he looks really well balanced. Knees are not collapsing inwards. His form looks really good and stable. So I like to do this just as a check to see how strong their core and glutes are. What we don't want to see is like knees collapsing in this way or kind of like, you know, that type of posture. If so, I have some PT friends in the room that can help you. The other thing I'll check is like a single leg squat. So stand on one leg, bend down, good. And again, you're looking for knee valgus or unsteadiness around the knee, just general balance and how stable he looks. Okay, try on the other side. Good, okay, you clearly practice for this, very good. And then the single leg hop, which we talked about for stress fracture rule out, so kind of just a couple hops on each leg. Perfect, okay, so other side. And I particularly do these in clinic, and I'll hop and squat in clinic because then I don't have time to go to the gym after a long day. So it's like, if I do squats with like all my patients, then it's like at least at like 3 sets of 10. Okay, and then the last thing I do is watch them walk. So obviously, you guys know what that looks like, but just, you know, watching their gait, seeing if they have, you know, equal time spent on each limb, seeing if they're favoring either side. And then if you want to actually turn and face this wall, this is how I do the Trendelenburg, which is an assessment of the gluteal tendon, but if you just want to stand maybe on just one leg. Good, so basically we're looking at here, if you look at like their pant level, for example, or their waist, that should stay level. And then if it does not, I can try to demonstrate, but basically, here, you're good. A Trendelenburg would be like, let me see if I can do it, kind of like this. Okay, does that make sense? All right, I think that's all we have for the exam. Thank you so much, Alan. Appreciate your help. Happy to take questions if you guys have them. Yeah.
Data on the arthroscopic procedure for FAI, preventing an inevitable total replacement.
No data. No data on prevention of hip replacements. I think the thing that's really tricky is we know a lot of people have it. We know it's a precursor to arthritis, but it's really hard for us to justify operating on an asymptomatic person unless we know that's actually going to change the natural history. We also know there's a lot of people out there living with arthritis who do not end up getting a hip replacement, who are not that symptomatic. So, to be determined, I think, in the future. I don't think we're at that point yet. And the analogous condition would be like, you know, your adolescent idiopathic scoliosis patients where curve past a certain degree, fails bracing. Okay, surgery, even if you have no back pain, because we know it prevents complications like lung issues, et cetera, later. We don't really have that level of data for hip. So right now, currently, the gold standard is to consider surgery for those who failed non-operative care and who are having current symptoms, either impacting daily life or sports, not as a preventative. So if I see people with imaging findings, some mild symptoms, usually we'll say, you know, hold off unless it gets worse. But I think, you know, we'll see what the data shows in the years to come. Yeah, thanks. Yeah.
So an adolescent girl with the femoral neck stress fracture, you mentioned the loading tests. So at what point are you doing those tests, and how is that used to determine how they progress with their training?
Yeah, is this in someone who's already been diagnosed? Yeah, so usually if they're already diagnosed to have a stress fracture, for me, they would be crutches, touchdown weight bearing for about 4 to 6 weeks. And so for hips specifically, and our PTs in the room will already know this, but non-weight bearing, so actually holding the foot off the ground, actually increases the joint reaction force compared to putting your foot flat on the floor, and actually relaxes the hip flexors too. So I want them to use crutches to offload, and they're putting the foot on the floor just for kind of balance, but they're not like putting significant weight through that leg. So that would be the weight bearing protocol for 4 to 6 weeks. And then what I would do is have them, with their PT's guidance, transition to off crutches. So go to putting weight with their crutches and then go to one crutch, see if they tolerate. At any point, if they don't tolerate, then back off. I wouldn't do any hop tests for them until like much later when they're thinking about getting back to impact activities, probably several months into the process. But really, any pain for me is a sign to kind of back off for those patients. Yeah, thanks. Maybe one question from this side of the room.
For FAI, do radiologists comment on the bumps that you see on the X-ray? And if so, how would they describe them?
Yeah, so the radiologist will often say like osseous prominence at the femoral head-neck junction. Yeah, verbatim.
Is there a particular X-ray you order?
Yeah, so I like to get AP of the pelvis and then some sort of lateral of the hip. There's lots of difference, either frog lateral, I like a Dunn lateral, so a slight variation on that.
What kind of lateral?
Dunn, D-U-N-N.
Done.
I think some lateral, any lateral is fine, just a lateral. Yes.
Have you used bisphosphonates to treat some of the bone marrow edema?
Ooh, good question. I personally, I would say I do not prescribe bisphosphonates as an orthopedic surgeon. I think it is interesting. There's probably some data to support that, but I think I would, for that patient, feel more comfortable with them being seen by perhaps an endocrinologist who can help us manage some of those meds and talk to them about side effect profile as well. Yeah, good question though. Yeah.
Did you say how much heterolactate you use for joint versus?
Usually 30 milligrams. Sorry, let me repeat the question. He is asking how much of the ketorolac for the injection, either peritendinous or intra-articular. Usually about 30 milligrams. It's per 1 milliliter, and then plus local anesthetic of your choice. Yeah.
So I know, like, historically, you recommend no more than like 2 or 3 corticosteroid injections in a year. Have you guys looked into like if there are going to be limits on how often you could inject ketorolac?
Great question. I don't think there's any data. I think we all have just said like probably don't repeat it for a couple of months. You're space about a couple of months. I think number one, because it makes sense to kind of space out to see if they're efficacious, also to give patients some time to do other treatment like physical therapy. I don't think there's any data to say how frequently ketorolac should or shouldn't be given though. Good. I think we just extrapolate that data from corticosteroid. Yeah.
Today you discussed for FAI about CAM infringement specifically. Can we assume for the sake of this lecture that it's about the same for pincer?
Yeah, thanks for that question. I took the slide out because I just didn't have enough space. But so she's referring to different types of femoral acetabular impingement. The CAM morphology is what we spoke mostly about. That's when you have a bump on the femur. It's a developmental condition. There's also a form called pincer. So instead of having a bump on the femur, you have an extra deep socket. That's a pincer lesion. And that's something that you're kind of born with. For all intensive purposes, treatment is the same. Surgical treatment a little bit different because we're kind of removing bone from different places depending on where there's extra bone. But yeah, pathology is similar.
And same for early onset OA?
In terms of?
Like prevalence of OA early onset.
Oh, you mean with pincer? That's a good question. I think it is higher with CAM type impingement. Actually, in terms of prevalence of early onset OA, it's usually with the big CAM deformities that have the highest association. Good question, yeah.
Steph, there's a couple of questions on the app.
Sure.
So what are some preventative prehab methods to reduce the risk / development of FAI in high school athletes?
So prehab exercises to reduce risk of development. I don't know that there actually are any. I mean, I have a lot to say about what you should do for prehab or warm-ups and exercise in general for sports, but I don't think any of them are going to be preventative of FAI.
And then one more there. Does retroversion or anteversion angle of the hip and or increased Q angle increase the likelihood of FAI?
Good question. So they're asking if anteversion of the hip or increased Q angle, which is the angle from your hips down to your knees, change the risk of developing FAI. Anteversion is a complicated topic. Anteversion is, and you can get anteversion from more than one place, but in simple terms, I like to describe anteversion as So if you think about the acetabulum, if you look at a three-dimensional model, the acetabulum are your sockets, right? They are typically slightly anteverted, which means they face slightly forwards. The opposite of that condition would be retroversion, which means that the hip sockets are facing slightly less forward. So like to the side, for example. They don't usually face backwards, so that's, so it's subtle. You can also have different degrees of femoral anteversion, so coming from the femur side versus the hip socket side. And the femur is typically also, mildly anteverted or mildly rotated anterior. People talk about combined anteversion, which is really complicated, so I'm not going to get into that. I would say that people with retroversion or slightly backwards facing or sideways facing sockets rather than anteversion can have impingement from that retroversion alone, which is a little different than pincer or CAM. So they can be a form of result in FAI, long story short. And we do think about it. Depending on the morphology, they can also result in dysplasia or like shallowness or undercoverage of the socket. But the hip joint is very complex, kind of three-dimensional structure, so probably a little bit beyond the context of this talk. Yeah?
I work in urgent care now, and I see a lot of people who work 60 to 80 hours a week, but they're also very athletic and competitive, and they come in with their injuries, and I say, I'm going to send you to the physical therapist. And they say, I don't have time for that. Just tell me what to do.
Yeah.
Like, what's the website?
Yeah. UCSF Sports Rehab, if you Google that.
Do they have some things?
Yeah.
Things to do?
Yeah, so
Okay.
so if you Google UCSF Sports Rehab, which is what I do because, well, we have the handouts in our office too, but that's what I do when I'm on a video visit and the patients, I can't give them like a physical handout. But if you just Google UCSF Sports Rehab, it'll take you to our rehab website, which will have different rehab programs for hip, knee, shoulder, spine. And then I think your job will be to figure out like which program to give them. So there's just like general knee strengthening, there's general hip strengthening, there's knee range of motion. So I think that can be a great resource. And I oftentimes will give that home exercise program also to patients in addition to PT if they're interested, because sometimes a PT, it's so, unfortunately, so limited sometimes in terms of just access and appointment availability. So if it's going to be like 6 weeks before they can get in, then I'm like, here, do this in the meantime. Go make your PT appointment. Hopefully you can start soon. UCSF Sports Rehab.
Question?
Yes.
So, I don't do any hip injections, but I do a ton of knee injections. And so this is the first time coming here that I've heard about Toradol as an alternative to corticosteroids.
Mm-hmm.
And has there been research done on the knee?
Yes. Yeah, most of the research is done on osteoarthritis patient populations, but yes, also for knee arthritis as well.
And so does this, so a lot of times if I have a patient who is thinking about a knee replacement, I don't want to inject it with
Right.
corticosteroids. Can I do that with Toradol though?
I think the joint replacement surgeons would say any injection within, usually they'll say, and don't quote me because I'm not a joint replacement surgeon, but usually within like at least 2 to 3 months of surgery, they would not want a joint injection. Yeah. Yeah, now sometimes you make an exception for like a diagnostic injection, like the MR arthrograms, for example, will oftentimes involve an injection. But again, I think the data is really extrapolated mostly from the steroid injection or the corticosteroid. I think we just apply it to ketorolac because we don't really have any other data.
Could you give it, say somebody's had a corticosteroid injection, and they can't come back to see me in 3 months, but it's killing me still. Can I give them a Toradol?
I think that's fine. So I have some patients, I think that's fine. I think I have some patients who say, we tried the corticosteroid injection, not effective. Didn't work, I don't want that again. What else do you have? I think it's fine if they don't have any contraindication to consider ketorolac in that situation. Awesome. Thank you, everyone.
Awesome, great talks. Thanks to our speakers. We have a coffee break now, so please enjoy a refreshment, visit the exhibitors. We'll see you back here in 20 minutes. Thanks, everybody. Welcome back. Our final talk of the afternoon is a dual talk, and so I have two introductions to share with you. First, I'd like to introduce Danny Keller. So Danny is one of our conference co-chairs. He's an amazing UCSF physical therapist who's a board-certified orthopedic clinical specialist, as well as an associate clinical professor in the UCSF graduate program in physical therapy. Danny is really a fantastic clinician. He's one of those physical therapists where I know that if a patient is seeing him, they're in the best of hands. And when he's not in clinic at our offices at Mission Bay, he's teaching in the DPT program and the PT orthopedic residency program. He's also at Cal Berkeley providing care to the D1 athletes. And he's always busy with impactful projects, including working as one of the therapists in UCSF specialized clinics for patients who have undergone limb amputation and osseointegration. And he's also done research in projects involving the development of exercise programs for NASA astronauts with low back pain. So you can ask him about space later. Like I said, I asked all of the speakers today about their favorite restaurants in the Bay Area. So for Danny, he said it was really tough to choose, but said his favorite place to eat is either Teleferic Barcelona in Walnut Creek, which is a buzzy destination for Spanish pinchos. Am I saying that right? Appetizers, paella and sangria.
Yeah.
Or Bee Patisserie, which some call, and you may know, pastry heaven here in San Francisco. So Bee Patisserie is a good one. Bee Patisserie, yeah, on California.
Can you tell me that first one again?
The first one is Teleferic Barcelona and Walnut Creek. They also have some other locations.
Thank you.
Yeah, you're welcome. All right, so that's Danny. And next is Tim. So Tim Baldwin is an ABC certified fitter of orthotics, a certified orthotic assistant, and a BOC certified athletic trainer. Tim's currently the Clinical Operations and Compliance Officer for UCSF Orthotics and Prosthetics, overseeing all UCSF orthotic and prosthetic clinics. He's worked in a lot of different settings within the Orthotics and Prosthetics Department, including the Orthopaedic Institute, the Mount Zion inpatient setting, and various clinics at Redwood Shores and Mission Bay, both inpatient and outpatient. He draws on years of clinical experience to optimize operations and ensure compliance standards are met and exceeded. When I asked Tim about his favorite place to eat in the Bay Area, Tim recommends Twisted Donuts and Coffee, which is a family-owned classic donut place in the Sunset. On weekdays, they have classic donuts, and on weekends, they have crazy donuts. And those crazy donut types include S'mores Galore and Nutty Monkey. So head out to the Sunset District. I'm thrilled Danny and Tim are here today to give the first of their two talks for this conference. Today is on knee and hip, and tomorrow on shoulder, foot, and ankle. We've asked them to pick a few high-impact interventions, whether exercises or bracing, we can provide our patients and athletes in the training room or in the clinic, in this case today for hip and knee problems. So please join me in welcoming Danny and Tim.
Okay, I'll start.
Mine work too.
Ooh, all right. Tim and I are going to dance around a little bit for you guys. We're going to not stand at the podium. If our mics cut out, we'll just yell, I guess. All right, so thanks for having us, guys. This is the first time Tim and I have done this lecture together, so it'll be fun. We have no disclosures to present. All right, so kind of what are we going to go through with this one? Bracing is generally a stepping stone, right? Both Tim and I agree that braces aren't long-term for the majority of patients. What is the focus of bracing? So the focus of bracing is going to be for pain control, stability in a short period of time, muscle assistance, activity tolerance, building confidence, especially post-op, preventative secondary injury, prophylactically. All of these things are what bracing is used for, but you can see a lot of these things are short-term, right? We can also use braces to assist in our exercises to improve efficiency and effectiveness, reduce pain while we're doing exercise. So we'll talk a little bit about that.
Yeah, so basic protocol that we wanted to show here is kind of how you could go from injury to brace to rehab to out of brace. And so a lot of times you'll start with an injury or a complaint. It can be chronic or acute, obviously. They have a reduced activity is usually why they're coming to you because there's something they can't do. That's why they want to be seen. A lot of times, if first intervention is bracing, especially in acute worlds, and it's because you want to limit things like range of motion. You want to provide stability so that they're not at risk of having further injury. You know, if you have a lower extremity injury, you want to brace them to lock them out so that they're stable because you don't want them falling and breaking a wrist or getting a concussion, which Dr. Center can tell you about after in other talks. And so that's usually where that first intervention comes in. From there, once they have their diagnosis and or their surgery, they'll go on to physical therapy. And the idea is that brace can either help promote that physical therapy, because if something hurts too much, some braces can maybe reduce that pain so that they can advance in physical therapy more, or it's to limit range of motions that they're not supposed to do yet, and it gives a good barrier for the PT to know how far to take it, how far not to take it on certain things. And then from there, we try to get back to return to play. And there are some braces that you will use in those return to plays, but most of those we will tell patients at some point you can probably stop using it. Now, there are some long-term patients. OA is probably one of your most perfect examples. Some people never want surgery. So if you're not going to physically correct it, something may be long-term for those purposes, but most of them you're going to tell people to wean out of and or stop using at some point. So hip bracing. There's not a lot of hip bracing. That's one of the things. This is usually for post-operative care in most settings. Or acute injury. So the one you're going to see most often is a hip T-scope. And what that means is it's a telescoping brace that can go up and down the leg to provide as much lever arm as you need. It usually controls either one plane or two. It can either be for flexion extension, but it can also control abduction, adduction. So there are certain braces that we can put special hinges on that can control those things to keep people in a certain position. Pediatrically is the one, if you do any pediatric treatment, that bracing is actually a first intervention and they're in all the time. And that's usually for a hip dysplasia issue. So when it's diagnosed early, it can be, I've fit babies as early as a week and a half old, that they can be put into this. And it's usually because they have a hip socket that isn't fully formed or not perfectly formed. They can't really go to PT. I don't know how much PT you can do with a 1 week old. It's limited. So it's all about positioning for growth. So there are things like a rhino brace and a Pavlik brace that are pediatric specific that are really your first and only intervention for a while, and you're trying to avoid surgery with that. Otherwise, there are some active hip braces out there. One of them is for OA. You have a lot of runners that want this, but essentially it's going to pull you into external rotation to reduce OA in the hip. Studies on this stuff and the efficacy of it is minimal. One, it's not studied a lot. There aren't a lot of great studies on bracing in general. It doesn't have a lot of research behind it. So it's more about what you know, what you've seen, what you fit, what you've done. It can be effective, but again, it's not going to be your long-term solution. You're still going to need another intervention, whether it's strengthening, surgery, or surgery and strengthening, right? But I have had people that say, I've got a marathon in 6 weeks. I just got to get through it. Something like this could be helpful, but it's really hit or miss with this type of stuff.
One thing from a PT standpoint, how many PTs are in the room? Raise your hand if you're PT. What's up, my people? All right, we'll do our handshake later. One thing that's really important from a rehab standpoint that I see a lot, especially in newer PTs, is understanding how to adjust a T-scope, right? We see them consistently, and we're taking them on and off more than anyone else, except for maybe the patient themselves, if they're supposed to or not. So really make sure you understand how to adjust the T-scope and how to make changes to it, because every once in a while you'll see somebody come in and that T-scope has been adjusted very incorrectly, and the patient's talking about how they have pain, it's changing the way they're moving, those types of things. So you need to understand how these work. If you don't know how they work, play with them, get a test one, go talk to somebody who fits them, and help get an understanding for how to fit these correctly, where the pivot point's supposed to be, the axis of rotation, how the straps are supposed to be tightened. It's super, super, super important. All right, so hip rehab. So there's about 1 billion exercises that we could go through for hip rehab. I don't want to spend time going through 1,000 exercises. You guys can if you want. But we were just going to talk about some kind of basic ideas behind hip rehab. And then if you guys have questions on specific exercises or specific situations you want exercises for, you can definitely let us know. So post-operatively, how do we use these hip braces? So in general, using these braces, especially things like the T-scopes, help us understand where range of motion limitations are at. So with a lot of these protocols, you heard Dr. Wong talking about kind of keeping that foot flat, hip neutral position after a hamstring repair. Understanding where range of motion limitations are is really helpful when the range of motion numbers are on the brace. It also helps your patients to understand it because we might be able to measure in the clinic where 30 degrees of knee flexion is, but they may not understand where that is, right? So we can keep them in the brace when they're doing their exercises like that. And if the protocol is a 0 to 30 range maximum, we can keep that brace set at 30. They can go until it stops, and it allows us to make sure they're doing it safely, effectively, and following that protocol. So this is where one place where braces can be extremely beneficial from a rehab standpoint, right? Weight-bearing exercises in the brace to provide support initially. So as they start to get weight-bearing, you'll see a lot of weakness, apprehension, these types of things when they first start, right? So we want to make sure that these braces are used to help back up that support system, to give them some support both externally and then also mentally to make them feel more comfortable and confident as they're getting more into weight-bearing activity. From a non-operative standpoint, most of my patients are only in the brace if it's more comfortable for them to do their exercises and more efficient for them to do their exercises. So I really like patients doing exercises out of brace as much as possible. It's not going to make them weaker to do an exercise in a brace, right? I think this is one of the biggest myths that we all hear is if I wear a brace, I'm not going to get stronger. If I don't get stronger, I'm not going to get better. That's not the case. If we're doing exercises that promote strength within the areas that brace is supporting, there's no reason you should get weaker using a brace, right? I've heard people even talk about it with knee sleeves, right? Like if I wear a knee sleeve, I'm going to get weaker. There's nothing about that knee sleeve that's actually going to support your leg, right? So understanding that and using these braces to help supplement exercise is really, really important in the whole purpose of what we're trying to do.
And on to knee. This one has a lot more, so a lot more that you can talk about here. Also, we're going to have a lot of times for questions because usually with DME, we've learned in rehab, you guys want to ask more than you want to be told. So we'll have plenty of time for questions after this. But for knee, there's a ton of options, whether it's acute injury, chronic injury, it's post-operative care. You can take people through a progression of bracing with the knee specifically. So the most common that you're going to see for any knee injury is your T-scope. Now, they talked about earlier, you know, if you're a primary care, you see a patient, they had their weekend warrior, they likely tore their ACL skiing, they're swollen, lack of range of motion, all the normal things you're used to. Most times people will order a knee immobilizer. I call it the devil's brace because it's an awful, awful device. It's hot, it doesn't work well, patients hate them, they're hard to wear. They are, if you have a strong enough patient, they can overpower them most of the time, which is a problem. So you'll have patients that come in and our ortho surgeons will see them and they'll have a 10, 20 degree contracture because they were in the knee immobilizer, but they could bend enough in it that they kept their knee at that slightly bent all the time versus actually locked out in extension. And now you have to work through that before you can even get into surgery, or you have to go to rehab before you can have surgery, and those things happen. So though knee immobilizers exist, and if that's the only thing you have access to, it's better than nothing. But understand if you're expecting something that needs to go to ortho or actually needs range of motion control, go straight to a T-scope. The other big reason for this is, I'm sure as we all know, insurance is awful. And it's getting worse and worse to get coverage for any medical care. Bracing is getting significantly more strict on coverage as well. Most CMS, Medicare is always the most stringent. However, everybody is starting to follow them. So whatever rules Medicare has, everyone else is starting to follow. So the problem is if you put somebody in that knee immobilizer, which is relatively inexpensive, and it's a good reason why ER stock them and things like that, they might not be covered now for a T-scope. And that brace isn't cheap. It doesn't come cheap. And so you run into a lot of insurance barriers. So I always say in the initial, it's always a little bit better to overbrace than underbrace just because if that's the only thing they're going to have covered, I'd rather have them have a T-scope that has controllability, that you can adjust range of motion, that's breathable, that's more easy to wear, that you can fit multiple legs. Have that versus something else. So just remember that as well, that insurance is getting very tough, especially with knee bracing. So just be careful how you prescribe because it could change what they have covered in the future. But so they have that T-scope. You control your range of motions. For patients that maybe have more of a chronic, I see this a lot in the elderly patients. They can't tolerate a T-scope. It's too big. It's a little too heavy. There are wraparound type braces that have a T-scope hinge to them now. So you can still lock a patient out. It's not as good as a T-scope as far as controlling, but if it's the only thing your patient can tolerate, or if you have a tiny patient, they work really, really well, and it allows you to progress that range of motion. For OA, I could talk an entire presentation on loader bracing. Long story short, are they effective and can they help? Yes. Are they good for everyone? No. They're kind of like KT tape. When it's used appropriately, it actually has a real use. Is it overused and not usually used appropriately? Probably more times than you would think. So, few things to know about OA bracing. One, they have to have mobility in their knee. And what I mean by that is on a varus or valgus stress test, if that knee doesn't move at all because the arthritis is so bad, a brace isn't going to help that. So they don't have the ability to offload a joint because that joint's not going anywhere. So that's number one for any osteoarthritis bracing. The second is compliance usually. Can you get them to wear it and how effective can that be? So for unloader bracing, they do have double upright and single upright. What I tell most of my patients, for a single upright, it's for smaller patients. So if you don't weigh a lot, we have a population in San Francisco of a lot of women that are 5 foot and 100 pounds. You don't need robust on them. Small works just fine because the amount of force you need to correct isn't that bad. Number two is their activity level. If you're playing basketball, you will overpower any single upright unloader. The impact is too much. You have to be in a double upright to get actual control and unloading. So that's how I kind of talk to my patients when they're like, well, can I have something smaller? No. Can I have something softer? Also no. A blanket doesn't control you as well as a straitjacket, right? You need that hold to actually create correction and do those things. So unloader bracing is probably the thing everybody sees the most. Like I said, it can be helpful, and it's usually helpful in two ways. One, patients that can't have surgery right now, right? Knee replacements take recovery. People might not be able to take work off, or it's the holidays, or it's just not right for them financially. There's a whole bunch of reasons why surgery might not work right now. This can be a temporary Band-Aid to get them through their day, allow them to be ambulatory, get them back to some activity to get healthier maybe for surgery, things like that. The other patients are the ones that never want surgery. If that's the case, then yeah, let's give it a try and see if we can reduce pain for that person. If they're never gonna go under the knife to correct it, let's see how much pain reduction we can give them. So that's kind of how I approach OA bracing. It can be medial or lateral. There's a lot of options on it. There's custom and off the shelf. So it's there. It's like I said, I could talk forever about it, but those are kind of my pearls on OA bracing. And then for patellofemoral, again, probably the second most common thing people are seeing out there. It's a mixed bag. Can it help? Sure. Is it a cure? No. And that's why we do this, I always say, in conjunction with rehab, because if you don't get stronger, I don't care what brace I put on you, it's only going to last so long. You have to do other things to get better. One thing that Dr. Sender talked about earlier with McConnell taping, that's a great first step. Have them McConnell tape. See if it's effective in any way. If they're getting at least some relief from it, patellofemoral bracing may work in that short term to allow them to progress in PT, to do longer walks, around the block or something like that. Again, not the cure, but at least it likely has an effect to it. There's a lot of studies that are starting to happen, though, with patellofemoral bracing on knee extension assist braces. So that's kind of the new wave of patellofemoral bracing, where we're not actually focusing on holding the patella, controlling it, and not letting it go all the which ways. It's actually giving it extension assist so that quad tendon doesn't pull as hard and doesn't create as much shear force. Therefore, it reduces pain and swelling and those types of things. There's a couple brands that are starting to make these braces. There's a couple of our doctors that love it, that we've been putting it on patients. It's relatively effective. It's actually been working really well. However, it is a Band-Aid, so your patients still need to go to PT. They still need to get stronger. They still need to make gait corrections and deficiency corrections. The brace is only going to help for so long, and it's just your Band-Aid. So that's kind of the new wave of patellofemoral bracing, is actually extension assist style bracing. And then the other places that I use these are Ehlers-Danlos. It's a diagnosis that we see relatively often. I'm sure a lot of people don't, but the university sees everything, so I see it quite a bit. That's one where bracing likely is a long-term answer, because they're always going to have this. They're always going to have this joint laxity. And so long-term bracing tends to help, like I had a girl once that wanted to fish with her dad. That was her only thing she wanted to do. So we put her in double ACL functional braces so that she could brace her feet against the boat without her patellas dislocating from any excessive quick motions or MCL, LCL tears. And so we put her in double upright so her feet could support. And then we're not talking about wrist today, but we put her in bilateral exos to immobilize the wrist so that her wrist wouldn't sublux over and over when she would try to pull the rod back. For her, no surgery is going to solve her problem. PT can help, but again, she's always going to have issues. So for her, bracing was a long-term answer, and it works fantastic for that kind of stuff. So again, know your patient, know why you're bracing, and understand how that can affect them.
Hey, Tim, what's more expensive? Valet parking at the Hyatt or a medial unloader brace?
Long-term, definitely Hyatt parking.
Yeah, that's what I thought. Yeah. All right, cool. So let's talk a little bit about rehab with bracing. So Tim did a good job of kind of talking about how PT can play into this. So when we talk about it again, I'm going to break it into post-operative and non-operative. And what I'll tell you is that from a PT standpoint, we see a spectrum of post-operative protocols in terms of bracing, right? We can talk about ACL specifically. There's not good research on T-scopes after ACLs. We still see it 95% of the time, right? Most of the research does not support T-scope use after an ACL. It doesn't hurt, it doesn't help, but they're still used. So we'll talk a little bit about why that's important and where kind of I think that they're helpful. Who knows who's the first picture here overlapping my with word? Somebody's got it. No. Tom Brady. Good. All right. TB12. As long as number is easy. And then how about the bottom? Who's the bottom? Yeah. RG3. RG3 because he's had like 3 ACL tears. In one game, right, with a brace on. So post-operatively, we use that brace again to understand the range of motions for the protocol. Same thing as the hip, right? Generally, we're going to see more knee-based range of motion deficits in kind of more advanced knee surgeries. So things like Fulkerson osteotomies, where we have limited range of motion, quad repairs, where we have limited range of motion. It's really helpful in those kind of situations, right? We can maintain a locked extension position with weight bearing in some of these. These are important for things like meniscus repairs, where we don't want that loaded shear through the knee. Quad tendon repairs, again, which are like my worst nightmare, because if they start to bend a little bit early on, it starts to stretch and it's really hard to bring it back, okay? We also generally see quad tendon tears in older individuals who aren't as active, right? The quality's not as good. And so these are really difficult. And this is one place where I really do like braces, because it really forces those patients to slow down, stay straight, limit their range of motion, because we see big problems with this. You can perform exercises out of the brace a lot of times with guidance. So, if I'm with them in the clinic, I'm going to be watching that range of motion. An example I use a lot with our residents is meniscus repairs. So when we have meniscus repairs, most of our protocols at UCSF are limited to 0 to 90 degrees of flexion. I'm not going to sit there and keep measuring that degree of range as they go through. And most of these patients, when they get to that 6-week mark and they can pass 90 degrees, they're already going to be at 100, 110, 115 degrees. It's really common. What we want to really use that brace for is when they're at home, not going past that 90, not pushing beyond that range. I can make sure they're not pushing when they're in front of me, but I can't do that when they're at home. So it gives them that guidance, and it reduces that fear of, am I going past 90? Am I going to damage this repair? Am I going to create problems? So it really improves their confidence when they're doing their exercises at home. Improving their confidence improves consistency, right? It's the biggest thing that we struggle with in PT is keeping patients consistent with their exercises. There's 700 memes online of my patient not doing their home exercise program, right? The biggest thing that we can do as rehab providers is make sure that we're doing everything we can to make them more consistent, because generally it's something we're not doing right that's causing them to be inconsistent. Not always, but most of the time. Non-operatively, we use these braces for exercise efficiency, so reducing pain. So Tim talked a lot about patellofemoral pain, right? It's probably 60% of the stuff that we see in knees these days. So if a brace is helpful at reducing that pain, whether it's a tracking issue or just a chondral issue, whatever the cause is, if a brace can reduce pain and I can improve the efficiency of their exercises, now I can start to get some of that muscle activity going, right? One of the exercises we love in rehab, most of us, is knee extensions. I love doing knee extensions because I want to get those quads isolated. I want to get them stronger. Getting quads stronger helps to unload the joints. It helps to unload that patellofemoral joint if my quad works better. When I'm going downstairs, if I can control that eccentric load, then it's not putting as much of that forward shift into my knee and that load through the patellofemoral joint. If I can't do that, though, just with them at rest, but a brace can give me a little bit more tolerance to that, boom, let's go. Throw a brace on it. Let's make it happen, right? I'm not trying to improve their tracking right now. I'm just trying to improve their pain so I can improve that exercise efficiency, right? Same thing when they start to return to activity. If someone wears a brace and they can run for 10 minutes with 2 out of 10 pain and they don't wear a brace and it's a 7, why not wear the brace, right? Let's go running. Let's get them active. So that's really where these braces are going to come in handy. We can modify the range of motion. We can gradually wean from them over time, and that's the goal. We're always trying to gradually wean out of these braces so they don't have to become dependent on it, right? Some of them we can wean a little bit faster, some of them we can wean a little bit slower. Some of them have comorbidities where we may not be weaning from it. They may use it for the rest of their life, but it shouldn't impact their ability to progress, okay? Sometimes even a simple sleeve is more effective than some of these fancy braces that cost more than the valet parking, right? So more often than not these days, for a lot of knee issues, I'm telling people to just try a sleeve first. And what you're getting from the sleeve is similar to what Carlin was talking about with the taping, right? Like, how does it work? Majority of the stuff that we talk about with kinesio tape, the elastic taping, which works great for patellofemoral pain, or these sleeves is proprioception, right? And what you'll hear from every patient that you tape their patellofemoral joint with kinesio tape or rock tape or whatever brand you want, or put a sleeve on their knee is it feels more stable. That just feels better, right? That's that ability of your brain to understand that awareness of your knee. Where is it at in space? What's happening with it right now? And that proprioceptive improvement is what's improving their overall confidence. Your brain's alarm system's coming down, right? It's like, I feel more confident with this thing on. A sleeve doesn't affect you in a negative way at all, other than it's hot and maybe you get a reaction from the neoprene, right? So sometimes these sleeves are just as effective, if not more, than the $750 unloader braces. So something to keep in mind, both from a clinical standpoint and a rehab standpoint. Tim and I decided to throw a fun picture in for you of the complex cases we like to see at UCSF. So this top, for you guys, right picture. What do you guys see in this picture? What stands out to you in this picture? Somebody raise their hand and throw it out there. What's that? There is an elevated portion of the tibial prosthesis. That is correct. This was a revision TKA, so you guys know, history. Had a TKA with an extensor tear, and it got infected. Had to be redone after the antibiotic spacers were taken out. But what stands out to you? Why was this patient having a lot of pain standing up? The patella. Where is the patella? Sitting on the implant. Yeah. So he came in and he said, it feels like my patella is getting grinded down by my knee implant. And I said, yeah, that's what it looks like. So I can't even tell you that that's wrong, right? Sometimes we're like, oh, my shoulder's grinding in place. You're like, no, that's not a thing. That's a thing right there. That's about as thing as you can get. So Tim talked about changes that we're making in patellofemoral bracing. Is a basic patellofemoral stabilization brace going to work for this? No, right?
KT tape will.
KT tape will definitely work for that. Yeah, 100%. Also a cup, suction cups.
Yeah.
I'm gonna pull it up. One of the pain management doctors thought we could use magnets. That was cool. But the biggest thing here is we had to come up with an idea of how we could get him more comfortable in this knee. Because what I didn't tell you is that on his contralateral side, he's a hip disarticulation, right? An ambulatory hip disarticulation. So he has a prosthetic and he's learning to use it. But sit to stand, bending, walking more than 30 degrees of flexion, stairs, impossible. He had so much pain it would give out, right? The last thing I want when I'm trying to walk with my hip disarticulation patient is for his opposite knee to give out, right? That's my worst scenario. So one of the things we came up with was a knee extension assist brace, right? It's about the only thing that we have that can help him take some of the load off that patellofemoral joint. So this is one that we're trying with him to see, can we get a little bit better improvement in that pain, a little bit more function out of that knee, give him a little bit of help there since he can't tolerate strengthening the quads very much, right? And see if we can get some improvement. So this is where our brace can be really helpful in the rehab setting. Does that make sense?
And then just some take-home points, and then we'll go to questions. So again, bracing normally used in conjunction with physical therapy. It's a really big thing. You shouldn't use it as your cure. You should use it as your Band-Aid to help your cure. It does not make you weak. The one exception I will say is people that wear ankle braces 24/7. That's actually a bad thing. That one will actually atrophy your ankle. If you aren't doing exercises in between and or doing things outside of that brace, you will get a weaker ankle. Outside of the ankle, none of them truly are going to make you weak because they don't supplement the muscle, they support the muscle. So those muscles still have to fire in a knee brace. Those muscles still have to fire in a hip brace. And so that's why it doesn't make you weaker. The other thing is can be used for protection, whether it's range of motion or we talked about prophylactic. When you see a lot of those football players wearing knee braces, especially you'll see linemen, right? Every lineman in the NFL has a double upright ACL functional brace on. Most of them have not torn their ACL. It's actually one thing I tell every patient, a brace does not prevent injury. You can still get hurt in a brace. It can reduce the severity of the injury, and it can reduce the overall risk of that re-injury, but it can't prevent it. So those linemen are actually wearing it for when all their 300-pound linemen fall on their leg. You're hoping the brace takes the brunt of that force so that they don't completely rupture their MCL, so that they don't completely rupture their LCL. It's not to stop an injury altogether. It's actually to just reduce the severity of it. And then, you should never use your brace to supplement PT. If you're not getting stronger, things are never going to fully get better. And so that's one thing I always push home to every patient. You still got to do your home exercise program. I know you feel great in the brace, but go do those things in the brace then. Don't just wear the brace so that you don't have to do them anymore.
All right, let's go through a couple cases here. We'll throw some questions to you guys first, and then you can throw questions at us. So we have a 60-year-old male patient with complaints of right groin pain, which has worsened over the last few years. X-rays show KL4, or severe, right hip OA with subchondral cysts. His aggravators are prolonged walking, cold weather, sitting on a low, soft surface, getting in and out of the car, or pivoting over his right leg. He feels better when he's lying down, using heat, using NSAIDs, or moving for short durations. He's done a few rounds of PT with some improvement, but he still struggles with positional tasks. He's planning for a THA in 3 months due to availability. The surgeon had to go out of town. So some questions for you guys. What would we focus on in rehab for this? So one of the PTs in the room, why don't you guys give me one focus area? It doesn't have to be a specific exercise, but one focus area you would want to do. Increase anterior hip flexibility. Good? Okay. One other thing. I'm going to start calling on the PTs in the back that I know.
We know there's more here. You raised your hand.
Can't get away from us. Glute strengthening. That's always a good answer, right? Glute med. It's always glute med. Jaw hurts, glute med. Why not? So good. So we've got some flexibility, control, extensibility. We've got some stability. I like it. Good. What bracing could assist with this rehab? Tim talked about one. Tim, what bracing could help with this rehab?
So there's that one that looks like biker shorts that pulls that hip into external rotation and tries to reduce some of the stress on the hip. Now, it may or may not. That's one of those things. You don't know till you try, but that could get that patient to that 3-month mark and make it tolerable to get to that 3-month mark prior to surgery.
How long would they wear that brace for?
Till they went to surgery.
There it is. Could biker shorts work just as well?
It might. It's similar to like a knee sleeve, right?
Yeah,
Compression and proprioception can help. So you could tell them, you could try when you're going to go for your walk, wear something a little bit more compressive. Now, we don't want them in biker shorts all day. It's not good for a lot of things. But if you're trying to exercise and stay healthy prior to that surgery, right? The less, like Dr. Steiner talked about earlier, the less you weigh, 5% makes a big difference, right? So if they're trying to lose weight prior to that surgery or not gain weight prior to that surgery, and you're trying to keep them active, it absolutely could help. Case 2, 35-year-old female patient. She's status post left ACL. Tear was 3 weeks ago. Got in right away. Happened to know a good doctor. They were, next door neighbors. They watch each other's kids, so they got in right away. They're 1 week post-op from their isolated ACL with a hamstring autograft. Difficulty with full quad activation, not uncommon to have happen. They got a 10-degree quad lag, moderate effusion still. Obviously very fearful. They're guarded. And then they're using their bilateral axillary crutches with a pain 3 out of 10. T-scope brace. Yay or nay, PTs? Or anyone?
Who says yes? Raise your hand if you want a T-scope on this patient. See a couple, few. Steph raised her hand. She wants one. Who doesn't want a T-scope on this patient? Nobody wants to raise their hand because they're like, nah, there's surgeons in here. I don't want to talk about it, right? Okay.
So why would you possibly keep them in that brace?
Yeah, so the most important thing to me on this exam is their quad lag, right? And so for me, if they're having a hard time with quad activation, and there's no meniscus repair here, so we're weight bearing, and we're walking, and we're doing stairs, that quad's not going to work as effectively as I'd like, and it's going to fatigue really fast. And that, for me, is a fall risk and a re-injury risk, right? I treated a patient about 8 years ago that had an ACL surgery, was doing rehab. Her PT cleared her from the brace after about a week and a half, and she fell down the stairs, and she fractured her patella. And she was 16, played high school soccer, and was trying to go to college, right? So she ended up with a patellar ORIF, and now she's got patellar ORIF hardware on top of an ACL reconstruction that we're trying to rehab, and then they sent her to me. And so that's my worst nightmare with this type of quad lag, is that they're going to fall and create bigger issues, right? So in this situation, I do want that brace because it's going to give me a backup situation. If that person starts to get some quad fatigue and they start to have that knee giving out, I know that brace is going to be there to at least give some backup support until they can catch, right? And it's going to prevent bigger hyper knee flexion issues that could create some issues, or valgus collapse that's significant, right? Is it going to prevent it? No. Is it going to reduce the risk? Yes. So for me, when I see that quad lag, when I see that inability to really effectively use that quad, now I do want that brace still. All right. If we're going to brace it, which one are we going to use? Are we going to use the long one, or are we going to use the short one?
Yeah, for this year in the long. You need full control. You need lever arms to hold that in full extension. Plus, even in that scenario with the 16-year-old, how many 16-year-olds just sit around, 16-year-old athletes that have aspirations of playing college athletics, they're going to fatigue that muscle at school. And so though you want them to continue using range of motion, you can't trust them to do that when they're standing, and be smart. So what do? You say, hey, you're locked in extension when you're standing. When you're weight bearing, I want you locked. Why? Because I don't trust you when you're at school. When you're here with me, we'll do other things. When you're there, you're locked. But when they sit at their desk, when they go home, when they're doing their homework, they can unlock and continue to work that range of motion. But you need that true control, and you're only going to get that from a long T-scope.
Now, in terms of rehab focus, we talked a little bit about that quad. So one of the things that I see a lot is that when you have a quad lag and straight leg raise, they're just using straight leg raise to try to get straight leg raise better, even though it's an ineffective straight leg raise, right? So outside of straight leg raises, we need to be utilizing more quad-specific activities with these patients. Everyone's afraid of knee extension, but it's a great exercise for this patient. If I can put them at the edge of the table and really get them using that quad, I can even assist it a little bit with the other leg to start, right? Use that quad in isolation. Keep the hip flexor out of it. Focus on the quads. Now I'm going to start to get better quad activation, better quad control. Hopefully over time with a little less effusion, I might get a little less of that swelling inhibition. And now I'm going to start to get more of that function with that knee extension hold, right? But just using straight leg raise that's ineffective to make straight leg raise better, to me, it just doesn't make sense. So we've got to stop doing that, okay? Other rehab focus, right? We want to continue to work on gait function, control, making sure with that gait we're getting that good heel contact, that terminal knee extension, right? And then always glute med, because why not, right? So big focus on that quad though, isolated quad.
Questions? I don't have one. A brand that I know that does it well, you can Google them, is Icarus, Icarus. It's not a promotion for them. It's just they're one of the few that makes the brace. It's not a brace that's commercially found. And so they make them. And essentially what they did is they took a spring system throughout the brace that they weave in their 3D printing, and then there's a dial attached to it for like a BOA that you can adjust the tension. So you can actually turn the tension so high it locks them in extension, like you wouldn't be able to overpower the brace. But you can also control how much extension assist you get. So for like the other patient over here doesn't have a sound side to push off of, you can crank that extension up and allow them to really get a push and then turn it down so that they can then just have a mild extension assist.
So the T-scopes, how do you adjust for people's weight?
Most of them go up to 300 pounds of like allowable force on there. They do make XL ones that are even more robust. And then if you really need it, for us, we'd go custom if we really had to. And we'll build a custom device with stainless steel bars and stuff like that if we really needed to. It's pretty rare that you need that. We do bariatric. There's a bariatric population has a quad tendon issue. I'm sure you see that in your rehab where they rupture their quad tendons a lot. So we have to put these on when they do the quad tendon repairs, relatively heavy people. And most brands are going to hold up pretty strong to that.
In my urgent care, we have a standard brace, and then we have the short T-scope brace. We don't have anything long, and I always look at that and I look at the patient and is that really going to do anything? But you're saying if I put them in a knee immobilizer, then maybe their insurer won't pay for a better brace later. So how would you make that decision when somebody's kind of blown out their knee? I did an X-ray. They need to see ortho clinic. I don't know what it is.
Then I'm throwing them in a T-scope. I'm throwing them in the.
Even the short one.
Oh, so the question was, they work in the ER. They have limited brace options there. If they only have a short T-scope available versus a knee immobilizer, but you're worried about insurance covering another brace, what do you do? I'm going to err on the side of safety versus cost at that point. They may not want to cover a second brace. And there's other options. You can buy things online. You can do things like that. But I'm going to err on the side of caution and make sure I can lock them out safely so that they don't get that 20-degree contracture while they wait to go see ortho. That's what I'm going to do. There's one in the back. I want to give, somebody had their hand up in the back. Yeah.
Thank you. Two questions. First is there a contraindication to use the extension assist brace if there's a pre-existing recurvatum or if they're on that hypertension spectrum? And the second question is, do the trochanteric belts work for that 60-year-old patient that was waiting for the total replacement? Does that do anything? Does it do what the biker shorts do symptomatically?
So two questions. One, is there a contraindication to the extension or contraindication to, the extension assist? And then for the hip, does that BOA, is that going to help to get them to that next level? The BOA, I'll go with the hip first. It's hit or miss. It really is. It's kind of like some injections. For some patients, they work great. For some, they don't do anything. But if they can't have surgery and they need to be mobile, it's worth a try. I would at least give it the effort. For the extension assist, there's no real contraindication because you can have them fully custom made. So I have patients that have a huge recurvatum or genuvalgum or varus. That's when we go custom. If their knee doesn't fit off the shelf, you can go fully custom with those.
Yeah, and the adjustability of it is nice because it allows us, even in rehab, to kind of watch what they're doing. And if they're every time coming up and starting to try to hyperextend, then we can make that adjustment. So it's easy to kind of monitor and adjust just with a dial, which is what's nice about it. We don't have to send them back and have, orthotics do all these adjustments to it. It's easy for us to just dial down the resistance a bit.
A couple questions on the app. My patients buy all sorts of braces over the counter. Are any of them in the under $100 range any good, and which one should I buy? Reliable brands. There's a couple DME companies that are here in the areas over there. Go see them, talk to them. We're not gonna have people come in that we don't trust. So there's some good brands here. Go talk to them, see if they have some options on that. But as far as under $100 for the knee, no, in all honesty. Most of the ones that you're gonna find online for under $100 are not gonna give you support, especially if you're looking for like ACL or assist. They're just not, the quality is not going to match what you need it to do. An ankle brace, an ASO, absolutely. A wrist splint, totally. But not for a knee brace or a hip brace. Those are going to be more expensive than $100. But yeah, go talk to the brands in the back. I'm sure they'd love to tell you.
The only thing I would add to that is the sleeves, right?
Sleeves, yes.
Sleeves, there is a difference in the sleeves. You can do the Amazon sleeves and the neoprene sleeves. A lot of people react to the neoprene. They don't love it. So some of the more fabric-based sleeves, things like Incrediwear or Bauerfeind, are really nice sleeves. They're more expensive. They're still under $100. They're still cheaper than parking. but certain Bauer fines, yeah. But those are the ones that I tend to have people get if they have a reaction to the neoprene because they're a little bit nicer and they tend to stay up a little bit more. It's one of the issues with the sleeves is if you have quads, it slides down, so they'll tend to stay up a little bit better.
What about copper? Patients always ask me about copper.
It's great for electrical. It gets stolen a lot.
Yeah, it can be sold on the black market.
Yeah, you can make a lot of money on it. You should try selling those sleeves. Wonder if you could sell it. No, I mean, from a research standpoint, there's zero benefit to it. It has not shown any sort of change. I can tell you anecdotally, I've had patients that have come in with copper and it hasn't made any difference compared to the non-copper ones. So that's one of those infomercials I get mad at night. But outside of that, I haven't seen any difference.
As a sleeve, if it works for your patient, great. It's not, their claims are not scientifically backed. Next question. This one actually has to do with an ankle. We're going to talk about this tomorrow, but I'll do a very quick response to it. I always warn my athletes that taping, bracing their ankle may increase their risk of injury, stress to their knee due to the decreased mobility in the ankle referred proximally. Does bracing the knee cause the same risk, stress to the ankle? From the ankle to the knee, most braces aren't rigid enough to really make that difference. You are overpowering most ASOs. Now, not that they don't help. Again, they can reduce injury, but they're not reducing mobility to a point that you're going to hurt the knee, in my opinion. And then vice versa, or the other way to the knee, to the ankle. Most of the time, when we brace for the knee, we're putting them in a better gait cycle, and we're putting them in a more controlled, pain-reduced gait cycle. So those stride lengths tend to be longer and more accurate. They tend to be better, more repeatable. And so actually, I tend to find other body parts hurt less when you help the knee. So hips and ankles tend to feel a lot better when you're addressing the knee.
Yeah, I would agree. I don't think we see that down chain mechanism as much as we maybe see some up chain mechanism. Again, if you really lock that ankle down, sure, you're going to find another pivot point, but not the same thing with the knee. I totally agree. You're going to usually get improvement, not worsening or increased risk.
And then last one, T-scope case number 2. Would it be better to keep them in crutches, weight bearing is tolerated for quad activation, and encourage use versus using the brace? I'll let you start with that.
Yeah, so I mean, we're talking about case 2. So when we talk about this, the question was keeping them in locked extension, I think was the question. I don't really want to keep this person in locked extension. I would keep them on crutches, but I would still be weight bearing as tolerated. There's no reason to not weight bear. We want to get some load through that leg. The best way to get muscles working is to put load through them, right? So I don't want to make them non-weight bearing, but I do want to make sure I limit the amount of range of motion that comes from that brace in case it does give out. And I want to make sure that I'm giving them exercises that are promoting that load safely. So that's the biggest thing. So no, not weight bearing limited and not locked in full extension. I want them to learn how to use that 0 to 30 range. But I am going to keep them on crutches just to be a little bit extra safe for a little bit longer before I wean them off those crutches.
Any other questions? Yep.
You know, I see mostly osteoarthritis, degenerative disease, and or patellofemoral. Now these people show up with these sleeves. Are you telling me that a sleeve is good for patellofemoral?
Yeah, so the question was, he sees a lot of patellofemoral and osteoarthritis in the knee. People show up with sleeves. Are the sleeves really that great for patellofemoral joint? And I would say, I think the sleeve is enough of a brace with patellofemoral pain, yes.
But aren't you putting pressure on the patella?
Yeah, it's a good question. So is the compression enough to cause some issues? Sometimes. If it's a really sensitive patellofemoral joint, occasionally you'll see increased irritability in that sleeve, but you'll know right away. So I tend to find that the proprioceptive changes with patellofemoral pain are more important than the compressive force in a locked extension position. They're usually going to have pain with knee flexion at a certain angle, no matter if you have a sleeve on or not, because you're going to get so much compression through there. Those sleeves do stretch over time as well. So when they're new, they're a little bit more restrictive. They will actually limit range of motion early on, which sometimes is better because they don't get into those painful ranges. Most people with patellofemoral pain don't have pain with standing straight. They have pain with a slightly flexed position and load through that slightly flexed position. So that's usually where I'm going to see the most issues. So long answer to your short question, I think the sleeves are more beneficial than not. Sure, occasionally you might see a high sensitivity patient, but it's also going to control swelling if there's any swelling in there. So I like the sleeves a lot for patellofemoral pain. I think they're enough.
And there is such thing as a placebo effect. thinking you feel better, a lot of people feel better. There are plenty of braces I have put on somebody that I'm like, this isn't really solving your problem, but you put that brace on and they start dancing like Charlie in the Chocolate Factory when the grandpa gets the golden ticket, right? They're out of that bed and they're doing jigs. It sometimes that is what you need. And so is it curing anything? No. Is it truly supporting the knee joint? No. But do they feel better? That's a real effect. If that gets them out moving more, progressing more, being healthier, totally worth it. Worth $30.
You're on point with your analogies today. It was solid. I'm stealing the straitjacket one for sure. How are we doing on time, Carolyn? Any more questions?
And we'll be back tomorrow. Feel free to ask anything between now and then or tomorrow.
All right, thanks, guys.